Good morning and welcome, committee chairperson, vice chairperson, members, and guests. I am Maria Ellis, the Executive Secretary for the Medicare Evidence Development and Coverage Advisory Committee, MEDCAC. The committee is here today to discuss their appraisal and recommendations regarding the state of evidence for procedural volume requirements, especially pertaining to surgical aortic valve replacement, SARVs, transcatheter aortic valve replacement, TAVR, and percutaneous coronary interventions, PCIs, for hospitals to begin and maintain TAVR programs. The following announcement addresses conflict of interest issues associated with this meeting and is made part of the record. The conflict of interest statutes prohibit special government employees from participating in matters that could affect their or their employer's financial interests. Each member will be asked to disclose any financial conflicts of interest during their introduction. We ask, in the interest of fairness, that all persons making statements or presentations disclose if you or any member of your immediate family owns stock or have another formal financial interest in any company, including an internet or e-commerce organizations that develops, manufactures, distributes, and or markets consulting, evidence reviews, or analyses, or other services related to transcatheter or surgical aortic valve replacement procedures. This includes direct financial investments, consulting fees, and significant institutional support. If you have not already received a disclosure statement, they are available on the table outside of this room. We ask that all presenters please adhere to their time limits. We have numerous presenters to hear from today and a very tight agenda, and therefore cannot allow extra time. There is a timer at the podium that you should follow. The light will begin flashing when there are 2 minutes remaining and then turn red when your time is up. Please note that there is a chair for the next speaker, and please proceed to that chair when it is your turn. We ask that all speakers addressing the panel please speak directly into the mic and state your name. For the record, voting members present for today's meeting are Dr. Aloysius Cougette, Dr. Michael Sarangani, Dr. Gregory Damer, Dr. Anita Fernander, Mr. Nefertali Frankel, Dr. Smadar Court, Dr. Sandra Lewis, Dr. Daniel Ohlendorf, and Dr. Zoltan Torre. A quorum is present, and no one has been recused because of conflicts of interest. The entire panel, including non-voting members, will participate in the voting. The voting results will be available on our website following the meeting. I ask that all panel members please speak directly into the mics. This meeting is being webcast via CMS in addition to the transcriptionist. By your attendance, you are given consent to the use and distribution of your name, likeliness, and voice during the meeting. You are also given consent to the use and distribution of any personally identifiable information that you or others may disclose about you during today's meeting. Please do not disclose personal health information. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the Advisory Committee members take heed that their conversations about the topic at hand take place in open forum of the meeting. We are aware that members of the audience, including the media, are anxious to speak with the panel about these proceedings. However, CMS and the committee will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting's topics during breaks or lunch. If you require a taxi cab, there are telephone numbers to local cab companies at the desk outside of the auditorium. Please remember to discard your trash in the trash cans located outside of the room. And lastly, all CMS guests attending today's MEDCAC meeting are only permitted in the following areas of CMS single site: the main lobby, the auditorium, the lower level lobby, and the cafeteria. Any persons found in any area other than those mentioned will be asked to leave the conference and will not be allowed back on CMS property again. And now, I would like to turn the meeting over to Dr. Daniel Canos.
Thank you, Maria. Just wanted to publicly thank the panel for coming today and for the public who showed up as well. This is a very important topic for the Medicare program and for the coverage and analysis group. Currently, we do have a national coverage analysis open on transcatheter aortic valve replacement. One part of that analysis is the reason for this meeting, which is really to see the state of the evidence on procedural volume requirements. And then based on what we hear today, the coverage analysis group will go back and we'll take a look at it and make decisions on what we'll do next policy-wise. So really the focus of the day is about the evidence, and which is the key for us and what we want to hear about. The basis of the evidence and the panel input is what we will use to decide on next steps and what this might be. And again, I'd like to thank everyone and the panel for traveling, and I'll hand it over to Dr. Peter Bach.
Good morning. I'm the chair and non-voting member of the MEDCAC today. My job is to help the panel focus on the questions, review the evidence in an open format. My other job, which fails to bring much glory, is to keep everyone on time. So I'll apologize now for my future rudeness, which will inevitably crop up. To the extent that we go off time, no one will be penalized, if you will. So if you have a half hour, you have 2 minutes, whatever it is, you'll get that time. But I will insist that we keep things moving for the benefit of everyone involved.
Good morning. I'm Dr. Al Sajay. I have the pleasure of serving as vice chair for the committee today, and I have no financial disclosures.
Michael Cincagrani, I have no financial disclosures.
I'm Greg Damer. I have no financial disclosures.
Anita Fernander, I have no financial disclosures.
Naftali Franco, I have no financial disclosures.
Smadal Court, I have no financial disclosures.
Sandra Lewis, I have no financial disclosures.
Dan Ollendorf, I have no financial disclosures.
Zoltan Turi, I have no disclosures.
Mark Carlson, I'm the industry rep, and I have financial disclosures. I'm an employee of Abbott, and I have Abbott stock.
Patrice Nickens, I have no financial disclosures.
All right, we're going to get the day started now. The opening remarks will come from Sarah Fulton from CMS.
Good morning. Thank you for joining today's MEDCAC meeting. My name is Sarah Fulton. I work in the coverage and analysis group here at CMS, and we're really happy to have such a full room today. Thanks for joining us. The purpose of today's meeting is to obtain the MEDCAC panel's recommendations on the appraisal of the state of the evidence for TAVR, surgical aortic valve replacement, percutaneous coronary interventions, and other relevant structural heart disease procedural volumes for heart teams and hospitals to begin TAVR programs and for heart teams and hospitals to maintain TAVR programs. The panel's recommendations will be based on scientific evidence, assessing procedural volume requirements for hospitals and heart teams, both beginning and maintaining programs that treat Medicare beneficiaries. It is important to note that today's meeting focus is on whether having minimum volume requirements for these procedures is supported by scientific evidence. We are not discussing what the actual numbers for these volume requirements should be. TAVR procedures are used for the treatment of aortic stenosis. The procedure involves inserting a bioprosthetic valve using a catheter via transfemoral, transapical, and transaortic approaches. The valve is implanted in the orifice of the native aortic valve or a failed surgical bioprosthetic valve. The FDA first approved TAVR in November of 2011, and within 6 months, CMS established the current national coverage determination. To date, CMS has approved 24 clinical trials under the NCD to cover TAVR in investigational studies that have led to FDA approval of expanded indications. As expanded indications are approved by the FDA, the NCD provides for concurrent Medicare coverage without the need to reopen the policy or adjust claims processing instructions. The clinical trials CMS covers continue to explore these and other uses for TAVR, including in patients at low risk for SAVR, in asymptomatic patients, and for the treatment of severe aortic stenosis. Regurgitation. This slide, kindly prepared by our colleagues at FDA, shows the progression of FDA approvals since initial approval in 2011. As noted in my previous slide, Medicare coverage has been concurrent with each expanded indication. The current NCD is a coverage with evidence development, or CED NCD. Section A addresses coverage of TAVR for treatment of symptomatic aortic valve stenosis when furnished according to FDA-approved indications. Hospital and heart team requirements are included here and pertain to both infrastructure and procedural volume requirements. Hospitals and heart teams must also participate in a CMS-approved prospective national audited registry. CMS has approved the STS ACC transcatheter valve therapy, or TVT, registry. Section B addresses coverage of TAVR for uses that are not expressly listed as FDA-approved indications. Procedures must be performed in CMS-approved clinical trials. These trials are listed on our website, which is provided here. The NCD specifically non-covers TAVR in patients who have existing comorbidities that would preclude the expected benefit from correction of the aortic stenosis. On June 27th, we opened a reconsideration of the current TAVR NCD, which resulted from a complete formal request. The request challenges the inclusion of procedural volume requirements, recommends coverage be based on quality outcomes instead of non-TAVR procedure volumes, and program qualification be based on physician-operator education, training, and skill. The analysis process for this reconsideration began with a 30-day public comment period, which closes this Friday, July 27th. The proposed decision is due on March 27th, 2019, and posting of the proposed decision initiates the second 30-day public comment period. The final decision is due 90 days after the proposed decision is posted. To follow the analysis, please periodically check the tracking sheet. The link is listed on the website. The website is listed up here. You can access public comments here, and when posted, the decisions, both the proposed and final, will be available as well. Thank you.
Thank you very much, Sarah. We'll have our first speaker, who's Peter Pelican. Dr. Peter Pelican is Medical Director of the Cardiac Cath Lab and Structural Heart Program at the Pacific Heart Institute and Providence St. John's Health Center. Thank you for coming.
Thank you for having me. Ms. Ellis, Ms. Fulton, Dr. Canos, Dr. Bach, committee members, colleagues. This has been a long journey for me here, and I'm very happy to be here. I have no financial conflicts. I am the medical director of the cardiac catheterization lab at St. John's Hospital in Santa Monica, California. About 5 or 6 years ago, one of my patients had a TAVR at an outside hospital. She happened to be a nun. And as I watched this sick heart become a healthy heart in about 5 heartbeats, it was literally a religious epiphany for me. And I fell in love with this procedure and decided I had to learn how to do it, which I've done, and I've been doing for the past 5 years. During that period of time, I drive an hour to an hour and a half to another hospital that met the NCD volume requirements, and then I drive an hour to an hour and a half back. It's about 15 miles, but in Los Angeles, that's the time frame. And my patients' families have to do the same, or they have to stay in a hotel at this hospital. So today we're here to discuss why that is and whether we are ripe for a change so that other hospitals, then high-volume hospitals, can perform TAVR. When the NCD was issued, there are a variety of requirements. I'll just review them briefly. I'm sure most of you are aware of them. But 2 surgeons needed to approve the procedure. A heart team model needed to be in place, which included cardiology, multidisciplinary members, and appropriate infrastructure in the hospital had to be present, such as on-site cardiac surgery, cardiac cath lab or hybrid room, echo, and ICU. And procedural volume requirements were mandated. So for a hospital without prior TAVR experience, they had to do 50 surgical aortic valve replacements, 1,000 cardiac catheterizations, including 400 or more percutaneous coronary interventions. I'll refer to those as PCIs. During the prior year, 2 cardiac surgeons with 100 career surgical aortic valve replacements, 10 of them high risk, and 25 aortic valves in the prior year, or 50 in the past 2 years, were required. For the interventional cardiologist, the requirement was 100 or more lifetime structural cases, or 30 or more left-sided structural cases per year, at least 60% of which were balloon aortic valvuloplasty. At the time of the NCD, ASD and PFO closure were not counted. Watchman or left atrial appendage implant procedures were not counted in terms of the cardiologist's structural experience because Watchman was not FDA approved at the time outside of a research setting. As mentioned, the participating hospitals must enter data into the National Registry as a team with the cardiologist and cardiac surgeon working together. For hospitals with prior TAVR experience, there were similar requirements. They had to have 2 cardiovascular surgeons on active staff, maintain a surgical volume of 20 surgical aortic valves per year, or 40 in the last 2 years, and continued for the hospital to perform 1,000 caths and a minimum of 400 percutaneous interventions to remain a TAVR center. Today, we are here to discuss revision of the NCD, and I submit that the time is right to modernize the NCD. Initially, TAVR was a major foray, a new and experimental procedure carrying significant risks, and some of the physicians who really started that off and accepted those risks are here in the room today. You'll be hearing from them later. However, now the procedure has become commonplace and incredibly safer. For ethical reasons, the procedure was restricted to patients at high risk for surgical aortic valve replacement. Now it's approved for intermediate risk patients, meaning a 3% or greater risk of death during open surgery. And as you heard, low-risk patient cohort trials are in progress, and it is expected by all that TAVR will be open to low-risk patients when those trials are completed. The TAVR NCD, in an attempt to maintain patient safety, was based on several presumptions. First is that the volume of a procedure predicts the quality outcome of that procedure. For example, PCI volume predicts PCI quality. The second, which is a leap, is that the volume of a cath lab procedure predicts outcome of a different procedure. In other words, if you do a lot of coronary intervention, you're going to be a good TAVR center. Third, the presumption was that TAVR was a minor modification of surgical aortic valve replacement requiring active cardiovascular surgical non-catheter-based intervention, and that it was a high-risk procedure with a significant risk of crash thoracotomy in the cath lab. So in the next part of this talk, let's examine these presumptions and see if they're still ethical now. Does volume predict quality for cath, PCI, CABG, and, for example, left ventricular assist device or LVAD implantation? Does volume of non-TAVR procedures such as cath, PCI, and surgical AVR predict TAVR quality? For cardiac catheterization, simply stated, volume does not predict quality outcomes. The 2012 American College of Cardiology Society of Cardiovascular Angiography and Intervention, and you're going to be hearing from leaders of these organizations later today. But ACCF and SCAI consensus documents stated, because of the low risk of diagnostic catheterization, it is difficult to come to a consensus as to what would constitute a minimum caseload. They go on to say that using, and I'm quoting, using minimum case volumes as a surrogate for quality presumes that a high procedural volume equates to a high skill level. The relationship between procedural volume and outcome remains controversial. They recommend quality assurance, not volume criteria, to maintain a safe and effective catheterization program. Turning to PCI, we are going to find a weak or absent correlation with quality. Here's a paper by Mascucci in 2002 showing volume and quality in 14 hospitals in Michigan, entailing 18,504 patients. I stress this paper was 16 years ago. In that study, no correlation between operator volume and mortality was found during the hospital stay. They did find a correlation between volume and MACE, major adverse cardiovascular events. However, let's look at the actual data. So this is a graph from Mascucci's paper. On the x-axis is operator yearly volume, and on the y-axis is MACE. Each circle in this graph is an individual physician. There's a regression analysis showing a mild correlation of volume and quality. Do I have a pointer on here? Is there a pointer on this or not? No. Okay. Well, the line is a regression line, and you can see there is a correlation, but it's a very slightly tapered slope down to the right. But making the point, and you will see other graphs like this, at least from me today, in the lower left-hand quadrant of this graph lie numerous high-quality, low-volume operators. This paper from 16 years ago was in the early stent era. Stents, as I'm sure you all know, have made the coronary interventional procedure safer. A more contemporary study from the United Kingdom between 2007 and 2013, this is more into the stent era, showed no correlation of hospital volume and quality outcome, meaning mortality, for coronary intervention. As PCI has become safer, the organizations that you're going to be hearing from today, ACC, AHA, you won't hear from AHA, and SCAI, have altered their position papers. So in 2007, the position statement, which was based on registry data from New York and Michigan hospitals performing less than 400 PCIs a year, showing a higher mortality. I suspect that this position statement from 2007 is where the current NCD 400 case per year requirement came from. This paper was from data from 1998 and 1999, only really 5 years into the stent era. Even then, the authors commented that procedural volume was only one factor contributing to outcome and that technologic advancements might level the field. 6 years later, the update from these organizations, now using data from 1995 to 2013, showed quote-unquote moderate heterogeneity in the volume-quality relationship. They noted that studies for angioplasty before the stent area showed some relationship between volume and quality, but stenting had dramatically improved safety outcomes. They, at the time, and again, this is 5 years ago, based on data from more than 5 years ago, suggested a possible threshold of 200 coronary interventions a year. So the large cardiology organizations have gone with the data and changed their outlook and recommendations. When looking at individual operator volume and quality, the societies suggest that there may be a volume-quality correlation, but they also, again, note significant heterogeneity. And look at this graph, again, from the ACC SCAI update. quite similar to the other graph I showed you. These are procedural volume by physician and in-hospital mortality, and the R-squared value of 0.0057 shows a sort of somewhat of a correlation. The red line tapering downwards to the right is data suggesting that there may be a volume quality correlation, but as on the other graph in the lower left-hand quadrant of this paper graph, there are numerous low volume, high quality operators. Again, arguing that volume does not confer quality. The conclusion of the committee: overall, it is the opinion of the writing committee that the available evidence does not send a loud signal supporting a consistently strong relationship between operator caseload and mortality. When reviewing the volume quality question, it is also seen that statistics can mislead, and I'd like to just show you an example of that. This is a paper from the Intermax registry, 7,416 patients were studied, and hospitals doing 10 or less LVAD, left ventricular assist device implants, 11 to 30, 31 to 50, and greater than 50 implants per year were studied. If you look at the curves, the blue line, which is 1 to 10 implants per year, and the green line, which is greater than 50 implants per year, are almost superimposable. If there was truly a volume quality relationship, the greater than 50 curve should be the highest curve there, not almost identical with the lowest volume center. I had one of the statisticians from Providence at their medical data center review the data available from this article, and Dr. Chin's conclusion to me was that there really is no statistical difference between the highest volume and lowest volume center, yet the conclusion of the paper was volume implies quality. So I again ask everybody to keep in mind that these statements are made, but they're not necessarily supported by the data. For cardiac surgery, there are numerous papers showing that the correlation of volume and outcome does not really exist. I just show you one graph here from multiple hospitals in the state of California, published by Carey. Similar to all the other graphs I've shown you looking at volume and quality, there is a mild downward slope to the regression line suggesting there's some relationship between volume and quality, but as with the other graphs I've showed you, the lower left-hand quadrant shows numerous hospitals who are low volume but high quality. And if you look closely at this graph, numerous hospitals in the lower left quadrant who do less than 50 surgical aortic valve replacements per year will not, by the current NCD, be able to start doing TAVR, even though their quality is high. So, looking at volume quality relationship for a procedure, I hope I've debunked. Second question is, does volume of a procedure confer quality on another procedure? I did several PubMed searches. This one looks at the correlation between cath lab volume and TAVR quality. I've never had a zero-hit PubMed search in my life, but I got 0 hits on this. If you look at the correlation between and in the upper line there you can see what I searched on. If you look at the correlation between PCI quality and TAVR outcome, there are 0 hits. And if you look at the correlation between cardiovascular surgical volume and TAVR outcome, there are 0 hits. And to be fair, I searched using numerous terms, not just outcome, but mortality, et cetera. I got 0 hits on all of them. Now, since I've shown here that volume of a procedure is not predictive of quality, I'm sorry, I'm off slides here. As we saw with PCI becoming safer over the years, we see the same sort of thing with TAVR. And I initially said TAVR has become safer. I just show you this graph from one paper showing that the process matures. This is a paper from Israel on 1,285 patients at 3 TAVR centers in Israel between 2008 and 2014, showing that as the years have gone by, the procedure has become safer, the need for pacemaker implantation, the complication of infection have reduced, and there is a downward trend, although not statistically significant, for other complications. To get an idea about TAVR safety now, we queried the ACC TAVR registry for the 4 quarters ending Q3 2017. Of 45,395 cases, only 220, which is 0.5%, required emergency conversion to open heart surgery. Annulus rupture, only 39 cases, which is usually a fatal complication, but has become rare due to improved understanding of valve sizing, improved CT imaging, and better planning of the procedure. Overall, these numbers show that TAVR is a cath lab procedure and not a small modification of aortic valve replacement. So, showing that volume really does not imply quality, that TAVR is streamlined, and in the age of electronic records where we can actually measure quality and no longer need to use volume as a surrogate for quality, I propose that the time is now to change the NCD and use quality, not procedural volume, as a requirement for TAVR. So in no way am I saying we don't want quality, but we want to actually have true measurement of quality. If we continue to adhere to the volume criteria, there are a variety of outcomes that may not be good. For example, we know that since the development of appropriate use criteria, AUCs, the volume across the nation of coronary intervention is dropping appropriately, along with the effects of statins. So, ask a question. If procedural volume drops below 400 PCIs per year, should a high-quality TAVR program stop doing TAVR? I think that would be the wrong decision. If we leave the TAVR criteria in place, TAVR programs will also have an unhealthy motivation to meet minimum volume and might be motivated to consider performing unnecessary procedures. Consider also, if a program is doing 350 cases a year and brings in 10 operators each to do 5 cases, and thus reaches their 400 PCI goal in the NCD, will that improve TAVR quality? Again, the answer cannot possibly be yes. As TAVR has shown excellent results and now has been approved not only for high risk but also for intermediate risk patients, surgical aortic valve volume is dropping. TAVR is, as I said, a cath lab procedure, not a minor modification of surgical aortic valve replacement. So surgical volume should not be a factor in qualification of a TAVR program. Should a program performing quality TAVR stop doing TAVR if their surgical volume appropriately drops? Again, I would say no. Again, consider the potential motivation for a program to unnecessarily perform surgical aortic valve replacement in order to maintain their TAVR program. TAVR revision with removal of the volume criteria will allow new programs to open and provide TAVR for their patients. Patients and families will not have to travel for the procedure and not encumber expenses for that travel. Care quality actually, I believe, will improve because the patient will be having their procedure in their hospital with their primary care doctor, their normal group of specialists who have cared for them and know them, and their cardiologist. Lastly, since we would be basing procedural approval on quality, not volume, I submit that outcomes will actually improve. In other words, allowing low volume but high quality programs to exist will improve because there are programs, and again, I'm not trying to insult anybody, but there are probably high volume programs that are not high quality. And if we actually base our decision on quality, not volume, I believe quality will improve across the board. So what would a rational TAVR NCD look like this year or next year? Quality, not volume, should determine program initiation and maintenance. Operator training, experience, and skill should be the most important determinant of program quality and outcome, whether it be for the interventional cardiologist or heart surgeon skilled in structural heart catheter therapy and alternative non-transfemoral access that the cardiovascular surgeons provide. When considering operator training and skill set, MitraClip, transvascular mitral valve intervention, Watchman, as well as ASD and PFO cases should be included along with TAVR. These cases use the same structural heart skill set, combining CT and transesophageal echo imaging with fluoroscopy to deliver devices in three-dimensional space. Case numbers conferring proficiency for the operator can be argued, but the 100 structural cases seems reasonable to me, although again, I don't think there's any data to support that. The TAVR operator must be skilled in structural heart, PCI, and peripheral intervention in order to safely and effectively perform this procedure. So today, the committee is going to be voting on a number of questions, and as you can tell from the data I've provided, I submit that quality, not surgical volume, should be important in the program, whether that be for surgical aortic valve replacement, PCI, and I believe that the volume criteria for those procedures should be removed from the NCD. Similarly, for maintenance, we should be looking at quality, not volume. I believe that for a TAVR surgeon to perform the procedure, as I said, this is not a minor modification of a surgical skill set. So the surgeon, if he's actually going to be doing TAVR, should be skilled in catheter-based intervention, but also the surgeon who is participating should be skilled, as stated in the NCD, in surgical aortic valve replacement, as well as alternative access routes, whether it be direct aortic puncture or direct aortic puncture from a minimal sternotomy or subclavian access. Again, TAVR quality, I believe, is most dependent on the primary operator's experience. For the interventional cardiologist, they should be able to do structural heart, coronary PCI, peripheral intervention, and have sufficient case volume of the type of cases that I've mentioned, not simply TAVR or balloon aortic valvuloplasty. Volume criteria do create barriers for patients. They limit the number of hospitals that are able to do TAVR. As I said, in Los Angeles, it can take 1.5 to 2 hours to drive 15 miles, depending on the time of day. At 4 in the morning, not, but during waking hours, yes. Gender, ethnicity, race, and socioeconomic status will potentially be limited from access to TAVR because of the requirement for paying for a hotel, driving, coming back and forth to visit family, or for the patient themselves to get to a TAVR program. Community hospitals tend to be smaller, and I'm at a community hospital which is, let's say, medium-sized, very high quality, lower volume, and my community is basically excluded from TAVR. It's my hope that after considering the data today that the committee will vote to remove the volume criteria. Later today, based on my assumption from the ACC position paper that was released last week, which is proposed changes to the NCD guidelines, that paper does discuss how important quality is, which I'm very happy to hear, but they do not recommend complete removal of the number of cases, volume requirements, and with that, I have to respectfully disagree. For example, you will probably hear that they recommend doing 50 TAVRs per year instead of 20 TAVRs per year. Reading the fine print in that document, that statement is based on quote-unquote preliminary data from the Duke Registry. In that same paragraph, they go on to say that more data is needed because this isn't really a final finding, but yet still recommend 50 TAVRs per year. They recommend 300 PCIs per year. I don't believe that the data supports any of that. We need to move into the modern era and actually measure quality and have quality be the determinant. Thank you for your attention.
Thank you very much, Dr. Pelican, and thank you on the small point of being on time. We are ahead of schedule, which I suspect everyone appreciates. Next up are Dr. Carl Tomaso, who's a cardiologist at North Shore Medical Group, and Dr. Joseph Bavaria, who's the past president of the Society of Thoracic Surgeons, the Brooke Roberts William M. Director at Heart and Vascular Center, Director of Thoracic Aortic Surgery Program, Penn Heart and Vascular Center at the Perelman Center for Advanced Medicine. These are recommended speakers from the AATS and the American College of Cardiology, the Society of Cardiovascular Angiography and Interventions, and the Society of Thoracic Surgeons. Thank you very much, Dr. Tomaso.
Ladies, gentlemen, and panel, good morning. My name is Joseph Bavaria. I'm a cardiac surgeon at the University of Pennsylvania and former president of the Society of Thoracic Surgeons. I serve as co-chair with Dr. Tomaso of the writing committee of the 2018 expert consensus document. This document, which is a joint statement of 4 professional societies, was published last week, as you heard, on July 18th. You will hear many references to this document in the subsequent presentations today. Those references will refer to an early draft of the consensus document. We received valuable input from stakeholders and revised our recommendations based on the public comments during the fall. There are substantial differences between the 2 documents. Unfortunately, many of today's presentations include assumptions and conclusions based on the early draft consensus document rather than the final version. I would like to summarize the key final recommendations of the professional societies. Number 1, access to care is complex and multifactorial in the U.S. healthcare system. The TAVR consensus document recommendations support both high-quality outcomes and access to care. The document does not, I repeat, does not recommend closing of any of the current 584 TAVR programs in the United States. A major threat to growth of low-volume TAVR sites would be opening even more TAVR sites, especially in the same geographic regions. The document emphasizes the importance of the multidisciplinary heart team. This is very important. Quality metrics, rather than volume, should be the ultimate criteria for assessment of TAVR site performance, as you just heard. There is significant statistical complexity regarding the ability to accurately evaluate outcomes in low-volume TAVR centers. The most current analysis of the TVT registry data demonstrates a clinically meaningful association of higher mortality and other major comorbidities with site annual volume below the recommended threshold of 50 procedures per year. This is both Carl's and my disclosure slide. You'll note that my disclosures is mostly related to all the manufacturers and their FDA clinical trials. The 2018 consensus document is the result of a collaborative approach. There was equal representation on the writing committee with 16 total members. The 2012 NCD has been magnificent. The number of TAVR sites has expanded in the United States to 584, and TAVR outcomes have been improving yearly. This is a very important concept. So one of the questions is why volume? Why a minimal volume floor? There is a well-known and robust body of literature showing a volume outcome relationship in almost every complex medical procedure. This is true for TAVR as well. The volume-outcome relationship has really become almost common sense. It is why every patient in every office for every procedure in the United States asks, how many of these have you done, doc? So the professional societies decided to update the document. The TAVR registry, the TVT registry has given us a better understanding of TAVR quality, which was unknown at the time of 2012. The primary focus of the new document is quality, measurement, and risk-adjusted outcomes. As this slide emphasizes, direct, comprehensive assessment of quality is required. Volume is not a substitute for quality. This is a positive evolution. The document reports some core infrastructure requirements and recommendations. They include a minimum floor, volume floor, is required to reliably measure quality. The overarching importance of the multidisciplinary team, the importance of training, and institutional support for resources and facilities. The writing committee recognizes that one of the key quality issues is the substantial variability in clinical outcomes. It will be very important to determine the contributing factors to variability in TAVR quality through the CMS coverage with evidence development, CED. This is one of the most pressing issues in the near-term future. So Dr. Kanos asked for data and evidence. The next few slides are going to be data and evidence. Members of the panel, CMS initially asked about the validity of the volume-outcome relationship and why it is important. We will try to answer this question. Oops. Can I go back? There we go. The circles represent TAVR programs in the United States through December 31st, 2016. The x-axis is the observed over expected, or ODE ratio, of death at 30 days. Generally, any ODE ratio over 2 is certainly problematic. One of the things you should note about this slide is the average ODE ratio is 0.72, not 1.0.
Okay, I'm going to interrupt for just 1 second, not to get you off your talk, just so everyone realizes I'm not editorializing. This graph has the axes flipped relative to the prior speaker. It has no effect on the interpretation, but just so everyone knows, the volume was counted along the horizontal or x-axis by the prior speaker, and mortality was shown on the y-axis. This is the other way around. That's all. Sorry for interrupting. And you'll get those 15 seconds back.
Okay, where was I? Okay, on the y-axis is site annual volume, as you just heard. There are a few takeaway points. There is undoubtedly a volume-outcome relationship. It is dramatic. This initial 2016 analysis of the volume-outcome relationship was the canary in the coal mine that informed the writing committee to examine quality of TAVR in the United States further. 96%, another point, 96% of sites with an ODE ratio of greater than 2 were programs with less than 100 TAVRs per year, and most were less than 50 TAVRs per year. This slide shows the data, the same data, with all programs under 100 TAVRs per year removed. It shows that the volume-outcome relationship flattens at over 100 cases per year. This is a recent phase of care mortality analysis presented at the 2018 AATS meeting by the Michigan Quality Collaborative Group, studied the root cause of death and whether the death was avoidable following TAVR. The analysis revealed the highest percentage of TAVR mortality, at 41%, occurred during the procedural phase of the operation or the procedure, and 51% of those deaths were classified as avoidable. A volume-outcome relationship was then evaluated for TAVR. The graphic display you see here shows that TAVR exhibited a volume-outcome relationship as an exponential decay function with flattening of the curve between 50 and 100 cases. This volume-outcome relationship supports the consensus document recommendation that new program sites have an experienced proceduralist on the heart team to minimize avoidable deaths. In other words, to obviate the learning curve. These are a series of important slides. This is the most recent data, not from a while back. This is hot off the press from the TVT registry. It includes patients treated over a one-year period ending in 2017. The data was analyzed by the DCRI, an independent analytics center. The outcome shown here is 30-day mortality. There are three plots. The left is raw mortality frequency, and the next two on the right are mortality expressed as an observed to expected ratio, the O/E ratios. On the horizontal axis is site annual volume expressed as bins. This allows us to see the results for sites below and above a 50 annual threshold. The open circles represent the mean values of 30-day mortality rates. So, first, the absolute 30-day mortality is strongly associated with annual volume. The ODE results strongly suggest that low-volume sites have worse results. The red dots show individual site results. The colored bars of interquartile range show that there is variability in site outcomes that is greatest in the lower volume sites and minimal at the high volume sites. This slide highlights in yellow the results of sites below the 50 annual threshold. There are 3 points to be made. The average value showing a higher mortality at low volume sites is clinically meaningful. Death is death without statistical uncertainty. Uncertainty of the quality of care is problematic. We want a healthcare system structure and policies that provide greater, not less, certainty as patients, families, and clinicians make treatment decisions. The overall trend in the last 5 years of commercial TAVR in the United States has shown a steady and meaningful improvement in outcomes. These concerning signals for worse low-volume outcomes are buried in the overall improving results because the sites doing over 50 cases a year account for 84% of all cases performed in the United States. Finally, these results represent sites that have opened under the requirements of the original NCD, including the volume thresholds currently we now have in place. Reducing these thresholds would be expected to create a large increase in the number of low-volume sites, potentially decreasing volumes at existing sites, and thus potentially shifting the overall outcomes in the United States towards low-volume sites and away from much better results of the higher-volume programs. Reducing volume standards would sacrifice quality for expansion of access without any scientific evidence that 584, as we speak today, centers is inadequate. On this side, the blue shading highlights 30-day mortality rates that exceed 4%. There are sites above this threshold in all volume bins, except the two highest volume bins. We are focused on providing data so all sites can improve their outcomes and not, repeat not, on closing programs that fail to meet volume thresholds. Our immediate goal over the next 3 to 6 months is to provide CMS and others with more in-depth data, addressing additional questions CMS may want answered as part of the coverage with evidence development. We would suggest that any updated CMS policy via new NCD be based on solid evidence provided by this new data. This slide from the TVT registry answers the question of whether low-volume programs are treating higher-risk patients, and if that is the reason their outcomes are worse. The answer is no. They're actually treating lower-risk patients with worse outcomes. The next series of slides show how we interpret the relationship between volume and outcomes and the special conundrum of low volume. Programs in the green box are high volume with good quality. This is real. These results are statistically valid. High volume programs in the red rectangle, unfortunately, this is real as well. It represents statistically valid poor quality. These programs need remediation. If programs are low volume, there are wide error bars, and statistically, we cannot draw valid conclusions on quality. Simply put, quality cannot be reliably determined for low volume centers, either good or bad. This is the conundrum of the yellow and orange rectangles. This slide is basically the same concept, which I'll skip over for time purposes. This slide outlines the document's quality control recommendations for low-volume centers, in the sense that we want to not close anything, but keep them under good quality. The past few slides demonstrate that a volume outcome relationship is real. Programmatic TAVR volume requirements are essential. Quality cannot be measured at very low programs, at very low volume. TAVR is a complex procedure. There is a 6.5% need for alternate non-femoral access. This is the most recent data from the TVT registry. TAVR still has major morbidity and mortality. There's a high risk of pacemaker necessity. And there's a combined intraprocedural catastrophic risk for cardiac arrest, conversion to open surgery, need for emergent cardiopulmonary bypass, left main coronary occlusion, or aborted TAVR procedures. When you add them all up, any one of these catastrophic events occur in approximately 2 to 2.5% of cases. This data answers the question concerning the need for experienced cardiac surgeons and interventional cardiologists to perform these procedures safely. Slides 23, 24, and 25 will be addressed by Dr. Sheehan in a few minutes. I would like to also highlight other important sections of our consensus document that recommend multidisciplinary team review, which is one of the absolute keys to quality, the use of appropriate use criteria, and importantly, shared decision-making with patients and families. The TVT registry is presently engaged in developing robust quality metrics. We already have in-hospital and 30-day risk-adjusted quality metrics that all sites in the United States now receive in benchmarked formats. Sites also receive major complications on their dashboards. We are currently developing a patient-centered quality of life metric, which is a one-year alive and well concept. Some of you might know KCCQ. Most importantly, the TVT is developing a risk-adjusted composite measure which will be the basis for national public reporting of TAVR outcomes in the United States. This slide represents 3 examples of the methods the TVT registry will use for site and public reporting of quality metrics. One of the most important goals for the NCD and TVT is to answer new questions and future concerns through continued evidence development. Examples are shown here. There are many. TAVR requirements will be discussed by Dr. Tomaso and Dr. Sant at the later meetings. Importantly, though, TAVR volumes have been reduced and definitions have been broadened. At this point, I would like to introduce my co-chair of the For Society Writing Committee, Dr. Carl Tomaso from Chicago.
Thank you very much, Dr. Bavaria.
Good morning. Thank you very much, Joe. I am the co-chair of the 2018 Writing Committee document. I was the chair of the 2012 Writing Committee document. I am the associate director of the Cardiac Catheterization Laboratories at the North Shore University Health System in north of Chicago, former president of SCAI, associate professor of medicine at Rush Medical School. I'm an interventional cardiologist, but I'm one of the 4 writing committee members who do not perform TAVR. This morning, I will address criteria for initiating and maintaining TAVR as outlined in our current document and address some issues concerning access to TAVR care. This slide outlines the suggested experience for initiating a new TAVR program. In the 2012 document, the outline prerequisites for a TAVR operator included procedures such as experience with balloon aortic valvuloplasty and procedures involving large bore arterial access. In the current document, we have done away with these prerequisites. We feel that the actual experience with TAVR is necessary. the manuscript states that operators should have had an experience of at least 50 TAVRs as primary operator. In addition, participated in an additional 100 transfemoral TAVRs in a structured training program such as an interventional cardiology fellowship, surgical residency, or precepty in an established TAVR program. With the increased number of fellows and cardiac surgical residents being trained in TAVR, as well as the number of physicians participating in preceptorships, we think this number is appropriate, according to the learning curve outlined in several papers that Dr. Bavaria cited. We feel that TAVR operators should be experienced in TAVR, and the opportunity is available for such training. Board eligibility or certification in the appropriate specialty is necessary. Device-specific training is appropriate. The TAVR site must have an expertise in multiple imaging modalities, and the imager must be a member of the multidisciplinary team. This is the requirement for the TAVR surgeon in a new program. We feel that the requirements for the TAVR surgeon new TAVR program include a lifetime experience of at least 100 SAVRs, or 25 a year, or 50 over the prior 2 years. The surgeon should have done at least 20 SAVRs in the year prior to initiation of a new program. The surgeon should be board eligible or certified. As mentioned earlier, these requirements have been liberalized. In the 2012 document, it was actually aortic valve implantation. We have liberalized those in this document to include any aortic procedure involving the aortic valve. This is the institutional requirement for a new TAVR program. The PCI volume has been reduced to 300 PCIs per year. The institution must be an active participant in a registry. In regard to the quality, the PCI hospital needs to be above the 25th percentile for the most recent 4 quarters. To address Dr. Pelican's concerns, the inclusion of PCI as a requirement has been controversial, since PCI and TAVR are different procedures for different indications. In the 2012 document, the inclusion of PCI was used as a surrogate for an adequately sized cardiovascular program, including all the necessary adjunctive programs. PCI is important, as we have found, because in up to 40% of patients undergoing TAVR have significant coronary disease, and the presence of an established PCI program will help to prescribe appropriate approaches to therapy. In addition, 0.2% of patients undergoing TAVR will have a coronary catastrophe during TAVR and will require an experienced PCI team for bailout. Additionally, over 20% of patients undergoing TAVR will undergo an associated PCI during subsequent to the TAVR. Experience in vascular arterial interventions and repair is appropriate to assist with peri-procedural and post-procedural bleeding complications. An electrophysiology program needs to be available 24/7 because of the significant incidence of sudden dysrhythmias and need for pacing in the peri-procedural period. The SAVR requirements for a new hospital. This includes a minimal hospital volume of 40 SAVR procedures per year, or 80 over the prior 2 years. This includes, again, all aortic valve procedures, not just SAVR, as was the recommendation in the 2012 paper. Quality assessment program must be in place. There's suggested that active participation in a recognized database. The quality metric recommends a 2 or 3 star STS rating for isolated AVR and AVR plus bypass in the last year. 2 or more hospital-based cardiac surgeons who spend greater than 50% of their time at that institution are necessary. This was inserted in order to prevent a situation where a surgeon is involved in the TAVR program in name only. The reasons for these volume requirements are threefold. 1, to ensure an experienced surgical team in case of procedural catastrophe. 2, to allow patients to provide alternative therapy to TAVR. And most importantly, to ensure that the institution has an adequate volume of patients. The next slide is the overview of maintaining an established program. The center should perform greater than 50 TAVR cases per year, or 100 cases over the prior 2 years. This only pertains to centers that have been operational for 2 years. This allows a ramp-up of new centers. More than 84% of current programs in existence meet this volume criteria. In other words, 84% of the 584 programs, of the 450 programs that have been open for 2 years meet 50 cases per year. Documentation of multidisciplinary approach and patient access to all forms of therapy for aortic valve disease, TAVR, SAVR, and palliative care is necessary, and using a shared decision-making process. Active institutional participation in registry, heart team quarterly meetings. Documentation of incorporation of TAVR, SAVR appropriate use criteria in patient selection process, and obviously CME for all heart team members. The institution should perform greater than 300 PCIs per year, active participation in a recognized registry, appropriate PCI outcomes, and again, a vascular team and an EP team are necessary. The institution should perform greater than thirdly, again, broadly defined SAVRs per prior year or 60 years over the two to ensure maintenance of surgical skills. A quality assessment, quality improvement program is appropriate. Active participation in a database to monitor outcomes, and a quality metric of an STS 2 or 3 star rating for isolated AVR and AVR plus bypass in both reporting periods. I'd like to skip to access to care. I want to define access to care in 3 general areas. 1 is geographic access to care. 2 is access to care in minorities requiring TAVR. And 3 is access from primary care. This is a slide depicting all the U.S. TAVR centers as of May 1st, 2018. At this time, there were 579 sites. This is approximately 1 site per 556,000 U.S. population. If we compare this to the site density in other countries, Germany has 1 site per 840,000 population, France 1 site per 1.4 million population, and the UK 1 site per 196 million population. In these Western European countries with a combined population of 214 million, there are 178 centers, or 1 site per 1.2 million people. This is even more disparate if we look at population greater than 65 years of age. The U.S. has 15% of its population greater than 65, which translates to 1 site per 83,000 people older than 65. In Germany, where 21% of the population is over 65, this translates to 1 site per 177,000 people over 65. In France, 20% of the population is older than 65, and 1 site per 279 people. In the UK, this is 1 site per 374,000 patients over 65 years of age. Now, getting back to the map here, the blue dots are centers that have been open greater than 2 years, and the red stars are centers that have been open in the last 2 years. Several points to be made here. 1, Wyoming is the only state without a center. 2, 84% of centers that have been open for 2 years have an annual volume of greater than equal 50 procedures per year. If you were to superimpose a map of population density over this map, it would demonstrate that the TAVR centers correspond very well to the population density in the U.S., with a number of centers in the heavily populated Eastern Corridor, Florida, major Midwestern cities, and West Coast. Of note, the red stars, which denote the sites that have been opened in the last 2 years, have been opened in many smaller urban areas, including the southeastern portion of the United States and the far west. But almost half of the centers opened in the last 2 years have been opened on top of areas with existing centers. Do these requirements create unintended barriers to TAVR based on geographic location? With 584 current U.S. centers provide broad geographical access with rare exceptions, again, markedly greater than high-performing industrialized European countries already. urban TAVR access is hindered by healthcare delivery issues, such as narrow networks of payers, providers along with the upstream lack of identification and appropriate referral for aortic stenosis management. Next slide. This is the projected TAVR growth, that with increased indications such as low-risk surgical patients, treatment of bicuspid aortic valve disease, and aortic insufficiency, the number of TAVR procedures is expected to reach 100,000 by the year 2020. If at 100,000 TAVR procedures a year and no further growth in the 584 sites, that would yield an average of 172 sites, 102 TAVRs per site per year, or 3.3 TAVRs per center per week. It's unknown where the margin of profitability lies, the point of economy of scale, or what market forces will apply. But performing less than 1 TAVR per week, 50 per year, imposes significant stress on the resources of an institution and may deteriorate the operator's skill set. Unlike PCI, where STEMI has increased the number of centers to provide emergent care, there is little need for emergent TAVR. This is some demographics from the TVT registry. The median age of patients undergoing TAVR is 82 years of age. So before we're talking about patients 65. The median age is 82, and we don't have any data either in census, the US Census, or in the Medicare projections as to this older population. And there's a very narrow range in those patients. More than half of patients undergoing TAVR are men, which is somewhat surprising and unexplained, since in this age group there's thought to be a predominance of women. Do these requirements create unintended barriers to TAVR based on gender? Any potentially identified gender access issue reflects U.S. patterns of care rather than barriers created by inadequate number of U.S. centers. Further study of understanding gender disparities is ongoing in the TVT registry. 15% of Americans are African Americans and 17% are Hispanic. The numbers of TAVRs from the TVT database suggest that only 4% of TAVRs are performed in African Americans and 4.3% in Hispanics.
Dr. Tommaso, please try to wrap up.
I will. There are several other things to consider, including that in the census there's only 6.3% of Americans age 65 or older. We realize that the Medicare projection is an increase of 9% by 2020. It also note that the STS database, only 5.7% of SAVR were African Americans. The other issue I want to discuss in terms of hindrance to Americans in TAVR is the lack of education of primary care in understanding the pathophysiology, prognosis, and evaluation of treatment options in patients with aortic valve disease. This has been anecdotal and there's no data available. But all clinical cardiologists have seen patients present with end-stage hearts as a result of aortic stenosis, and those patients have been followed by a primary care and never been referred for care. It has been said too many Americans are dying from aortic stenosis. I think it better said that Americans who die from aortic stenosis have not gotten appropriate care. Education would go a long way in minimizing this problem. So in conclusion, quality variability, not access nor volume alone, is the key challenge. This document provides framework of moving from volume requirements to quality metrics, but adequate volume is necessary to assess quality. Low volume centers should have ongoing case review as metrics are unstable. All centers should engage in ongoing measurement and QI. Registry is essential to assess long-term outcomes and variability involving patient cohort. Evolving quality would suggest external review program to understand variability. Thank you very much for the opportunity to present here.
Thank you very much. Next, we'll have Dr. Martin Leon, who's the AdvaMed recommended speaker. Dr. Leon is a professor of medicine and director, Center for Interventional Vascular Therapy at Columbia New York Presbyterian Hospital. He's the founder and chairman emeritus of the Cardiovascular Research Foundation of New York City. Thank you, Dr. Leon.
Thank you. Well, you've been treated to a great deal of data, and I'll do my best not to be repetitive and to provide a slightly different perspective. AdvaMed did support my travel accommodations to attend this MEDCAC panel. And these are other relationships that you should be aware of that represent potential conflicts. Importantly, I've been an interventional cardiologist for 35 years. I've been involved in the early device development of TAVR for more than 20 years. I've been a principal investigator of the randomized partner trials for more than a decade. I've personally performed thousands of TAVR procedures as a primary and secondary operator, and I work at a center that last year did over 450 TAVR procedures and a hospital system that did over 700 TAVR procedures. My role in this presentation is truly to represent the TAVR community and its stakeholders, particularly the patients. Let me start with several caveats. The public health imperative is to deliver improved access to all AVR therapies with optimal clinical outcomes for all patients with severe symptomatic aortic stenosis. The data regarding the need for imposing increased minimum procedural volumes to initiate or maintain a TAVR center are imprecise and poorly validated. Recommendations rely disproportionately on expert opinions and do not incorporate quality metrics. Future significant growth in TAVR case volume due to expanding clinical indications must be accounted for in all decisions which may adversely affect patient access. The 9 voting questions posed by MEDCAC and the additional topics for discussion will be answered responsively as a supplement to this main presentation, and they've been made available to the panel. The purpose of my presentation is to provide needed clinical perspectives to frame the critical issues regarding procedural volume thresholds as a central metric for TAVR site selection, and to suggest alternative quality-based approaches which will optimize both patient access to and clinical outcomes after TAVR procedures. This is an overview of my presentation. There are many slides, and in the interest of time, I will scroll through some of them and focus on the ones that I think are most relevant. The entire presentation is obviously available for your perusal. Let's begin with background. This is the 50th year anniversary of a seminal manuscript in circulation describing the natural history of aortic stenosis, and an iconic figure, probably the most recognized figure in all of cardiology, demonstrating that once patients have severe aortic stenosis and develop symptoms, there's a precipitous fall-off from the standpoint of survival. We had an opportunity in the first partner trial to recapitulate prospectively those retrospective necropsy observations that were made 50 years ago. These data were published, and the 5-year follow-up were also published in prestigious journals. And this is a single figure which clearly indicates that in this population of 358 randomized patients, those that received non-TAVR treatment had a 50% one-year all-cause mortality, and TAVR had an absolute reduction of 20% in all-cause mortality in the first year, meaning the number needed to treat to save a life in the first year was 5. Now, these are data from a clinical trial. As we make public health statements, we need epidemiologic data, we need real-world US data. We've engaged the Optum electronic health record and claims database to try to get more information that would help us to make some of these decisions. The size of the population, 160 million records. These are older, younger patients, commercial Medicare patients. The scope includes multiple institutions. The depth is significant, including performance status, symptoms, traceability, and specificity. It's a rich database. I'm going to start with this heat map, which gives you an estimate of the US incidence of severe symptomatic aortic stenosis in 2016. It's between 250,000 and 350,000 patients, including both diagnosed and undiagnosed aortic stenosis. And I've superimposed here the SAVR centers and the TAVR centers that are currently practicing in the United States. Importantly, on this heat map, you see the AVR treatment penetration relative to aortic stenosis incidence in 2016. Overall, it's less than 35%, averaging 24%, despite over 1,000 surgical centers and over 450 TAVR centers. In fact, no state had over a 40% treatment rate in patients with severe symptomatic aortic stenosis. There are several factors that impact AVR treatment likelihood. In this multivariate logistic model, certainly elderly patients are less frequently treated. Blacks are less frequently treated. Women are less frequently treated. And depending on who the diagnosing cardiologist is and his interest in referring patients for AVR has a significant impact on whether or not patients receive any AVR therapy. So to summarize, untreated severe symptomatic AS has a grave prognosis. There's a wide gap between the incidence of this disease and AVR treatment due to both underdiagnosis, as was mentioned, but also undertreatment after diagnosis. Undertreatment bias is affected by multiple factors. Current access to AVR, either surgery or TAVR, is still suboptimal and will only worsen as case volumes increase in the future, recognizing that with this NCD, we are projecting well into the future. I want to spend a moment talking about TAVR evolution and growth. This is an important slide. It shows you the estimated U.S. TAVR growth between 2018 and 2025. This year, we expect to see close to 70,000 TAVR procedures done. By 2025, that number will increase to over 160,000. As a percent of total AVR this year, it'll be about 48% of all AVR will be TAVR. That number will also increase to more than 75% by 2025. So we expect that surgery for aortic stenosis will decrease at a time when we see a rapid and almost dramatic growth in TAVR based upon expanding clinical indications. So what drives this growth? Certainly the acceptance of a multidisciplinary heart team concept, which we all believe in, the commitment to evidence-based medicine clinical research, something that I feel strongly about. It's the evidence that CMS is asking for. Rapid technology advancement, simplification of the procedure, all of which has resulted in a striking reduction in complications and improved clinical outcomes, which I'll demonstrate to you in some subsequent slides. This is an interesting slide because it shows you the 24 previously done or ongoing randomized trials in TAVR throughout the world. It's an extraordinary outpouring of clinical evidence that has justified this procedure over the past decade. In fact, since 2007 in the United States, more than 15,000 patients have been enrolled in FDA studies, including 10 randomized trials with multiple generations of 4 different TAVR systems. There's no lack of data, which has informed the guidelines. Most recently, we focused on intermediate risk patients. And I want to share with you some recent data in a late-breaking trial presented at the PCR last month, where we looked at intermediate risk patients with the most current balloon expandable TAVR system, so-called SAPIEN 3, and compared data from the FDA qualification study and the TVT registry. So the FDA trial involved 51 high-volume, largely academic centers as part of a 1,000-patient study. If we scroll over to the TVT registry, we now have 453 centers, low, medium, high-volume centers involving almost 9,000 patients. The methodology was a propensity-matched analysis, 1:1:3, of the transfemoral population, very important, with 24 baseline covariates using a logistic regression model with S3 used as the control. These are the propensity-matched, again, in TF patients, 30-day mortality and stroke outcomes. We could not find a difference in all-cause mortality at 30 days if you were part of the FDA's 50-site study that were high volume versus the TVT registry, including all centers. The same was true for stroke. And if you look at other outcomes, exactly the same. As you generalize to well-trained sites that have had experience with TAVR, whether high, medium, or low volume, the overall outcomes were as good as the highest volume sites in the most recently approved indication. Certainly, there are many other clinical indications which we think will be served by TAVR in the future. And there's no question, I believe, and I think most of you in the room would agree, that this has been a breakthrough therapy with rapid evolution of technology, procedural factors, with an expected significant growth that will strain the capacities of many centers, threatening to limit TAVR access. And importantly, in the current environment of strict adherence to evidence-based medicine principles, careful site selection, rigorous site training, and continuous monitoring and oversight, the clinical outcomes have stabilized, they've become mature, and are excellent across the spectrum of TAVR sites under the current NCD case volume requirements, as shown in this most recent intermediate risk patient cohort that we analyzed. But the central question is the TAVR volume outcome relationship issue. Now, it's difficult. These are two Joint Society expert consensus documents. Many people who are in the writing committee are close friends. They've been drafted. They have significant health policy and patient access implications. We did not have access to the final version as we were asked to put this slide set together. But other than the preamble, I think it's quite similar to some of the earlier versions that we had previously seen. So these are important documents, and I'm certainly not trivializing the necessity to have consensus documents that are supported by multiple societies. But let me put this in some perspective. This is real-world perspective from 2017. There are 1,872 hospitals performing PCI, of which 1,103 hospitals perform surgical AVR, of which in 2017, 540 were performing TAVR. So of the hospitals that perform PCI, only 29% had access to a TAVR program, and of the hospitals performing surgical AVR, less than half had access to TAVR. Now, the TVT registry provides enormously valuable data. This is an important publication that initially spoke to the volume outcome relationship. It was initially an early experience from 2011 to 15. It was a consecutive case sequence analysis involving devices, frankly, that are no longer being used. The mean age was 83. The STS score average was 6.6. Almost 40% were over 8. These were high-risk patients. 30% were transapical. This is not the real world or the modern era of TAVR. They looked at unadjusted and risk-adjusted outcomes for 4 different outcomes: mortality, strokes, vascular complications, and bleeding. Let's just focus on mortality because this seems to be the focus for many people. If we look at the mortality in this case sequence analysis, certainly there were statistical differences suggesting that both unadjusted and adjusted outcomes were affected by volume. But if you look at the absolute difference in mortality, it's 1%. And half of that 1% is in the first 50 cases, which is undoubtedly the learning curve. So truly about 0.5% of absolute difference in mortality defining the overall volume outcome relationship in this early experience. In the transfemoral subgroup, which is now the state-of-the-art for TAVR, 95% of patients being treated that way in most centers, there was no association between site volume and outcomes in risk-adjusted mortality with a p-value of 0.15 and in both unadjusted and adjusted strokes. Now let's enter the modern era. This is one of the 2 currently practiced valves, the SAPIEN 3 valve, and this is from the TVT registry looking at unadjusted 30-day mortality. We could not find, using a case sequence analysis, any significant change in mortality associated with volume using the SAPIEN 3 device in the recent experience. If you translate that, and this is a carefully conducted weighted analysis of volume cohorts into low, intermediate, or high volume, you can again see there's essentially no difference in 30-day mortality, unadjusted 30-day mortality, or unadjusted 30-day stroke rates. Now let's look at hospitals that are seeing SAPIEN 3 as their first valve. Newly initiated hospitals, and there are 53 in this analysis from the TVT registry. And again, we could not see in low, medium, and high volume centers any significant difference in the unadjusted 30-day mortality in these new sites as well. This is not isolated to the SAPIEN 3. The self-expanding core valve in its current characterization, the Evolute R and the Evolute Pro, you can again see, if you look at TAVR volume and you look at mortality, there was no statistically significant difference from the TVT registry. In fact, 160 hospitals with TAVR outcomes, TAVR volumes of less than 50 achieved 0 in-hospital mortality. Similarly, if you look at this analysis slightly differently with volume cohorts, once again, you see no significant difference in low, intermediate, or high volume cohorts in a carefully weighted analysis. Now, these are the same data that was recently presented by my colleagues, and we have not been able to replicate some of the observations that were made in the unpublished data set that was presented, which is something that we should be discussing later today. Now, those were data from the TVT registry. This is the MedPAR data, which is all data, all valves currently approved in the United States to address the issue of whether or not either prior or current volumes of surgery or PCI have an impact on TAVR mortality. And in this combined slide, you can see that prior surgical volume, current surgical volume, prior PCI volume, or current PCI volume have absolutely no impact on TAVR mortality. These are the individual data from those 4 panels. Most importantly, from the MedPAR data analysis, looking at current TAVR volume and its impact on TAVR mortality, as you can see, there was no significant relationship that suggests that we should be urgently changing the volume requirements that have been in the current NCD. In fact, if you look at this again carefully and look at the mean TAVR adjusted in-hospital mortality, once again, you do not see a relationship as you go down to lower volume centers. And if you look at the upper bound of the 95% confidence interval, for the lowest volume centers, the absolute in-hospital mortality is only 2.2%. What is interesting is that if you look at surgical volume as its effect on surgical mortality, there is a relationship. It's not quite statistically significant, but the more surgery you do, the better outcomes you get. Not so with TAVR. Looking at changes in mortality trends over time are important. This is the same MedPAR data analysis, looking at in-hospital mortality. Let's start with surgery. If we go back to 2012, the surgical mortality was 3.9%. If we scroll forward now 5 years to 2017, it's 4%. It does not deviate very much and has not deviated very much. If we look at TAVR in 2012, it was 4.7%. Now in 2017, it is 1.5%, dramatically less than surgical mortality, despite the fact that the patients are almost 10 years older and the Carlson Comorbidity Index was 30% lower in the surgery patients. Now, there's a literature on AVR volume outcome. Dr. Pelican already alluded to some of it. We've exhaustively tried to do a search to see what data is there. We've identified 30 manuscripts we think are worthy of discussion, and I've summarized them on this slide. First, looking at surgical volume as a reflection of TAVR outcomes, only 2 studies and no relationship between surgical volume and TAVR outcomes. There are 2 other studies that indicate that increasing TAVR volume was associated with improved surgical outcomes. What about PCI volume and TAVR outcomes? There are no manuscripts and only 1 abstract showing no association between PCI volumes and TAVR outcomes. How about TAVR volume predicting TAVR outcomes? There were 26 studies. 7 reported no relationship. 19 reported that as TAVR volumes increased, adverse TAVR outcomes decreased. The 19 reports showing a relationship were limited by small sample size, poor control of confounders, and early, before 2016, time bias in all cases, and none really assessed specific recommended volume thresholds that would alleviate the situation. You know about the existing TAVR programs, NCD, and at least the information we had about the draft multi-society consensus document. Currently, the institutional surgical volume, 20 per year or 40 over 2 years, with a recommendation to increase by 50%, but liberalize the definition of SAVR, per year or 60. So increase the surgical requirements at a time when surgery is going down. And the institutional TAVR volume from 20 per year to now 50 per year, a 2.5-fold increase as the base, as the minimum volume threshold to be a TAVR center. It gets worse when you talk about new TAVR programs where the expectation is, and these are essentially lower volume sites, you have to have at least 40 SAVRs or 80 over 2 years. And when you look at the requirements for an interventional operator, and that could be either a surgeon or an interventional structuralist, 100 transfemoral TAVRs with 50 as a primary operator, placing significant burdens on starting up new sites. So let's do some scenario testing. If you apply the 50 TAVR, 30 surgical annual volume requirement, looking at 2017 data from the 540 centers opened, you would find that almost 40% would not fulfill those requirements, and you'd have to decrease the TAVR centers in the US. It's nice to hear that we're not going to be closing centers, but when you publish these kinds of thresholds, the impact has nothing to do with what the society says, but certainly CMS may be obligated to enforce, and institutionally and administratively, it imposes significant burdens. When you look at that same heat map that I showed you on penetration, every one of these circles would be eliminated if you apply that 50-30 threshold. And among those, the white circles are centers that had achieved 0 mortality in 2016. So 70% of the below volume threshold TAVR sites had no mortality in 2016. If you try to talk about how we're going to potentially increase numbers of TAVR sites, and you look at the existing surgical-only sites, less than 25% would be eligible for TAVR based upon the increased volume requirements. So TAVR outcomes have not been affected by either surgery or PCI volumes. The MedPAR data is conclusive. The TVT registry had indicated an association between TAVR volumes and TAVR outcomes in the early analyses, which is difficult to dissociate with learning curve issues related to a new therapy. The recent TVT registry analyses involving new devices after 2015 have shown no volume threshold outcome relationship with SAPIEN 3 or Evolut R Pro, the currently practiced devices. And scenario testing clearly indicates that arbitrarily increasing the TAVR and SAVR volume requirements will adversely affect patient access. So finally, some additional topics and program recommendations. I read carefully the consensus document. It's an extremely well-written and thoughtful document. I appreciate the addition of the preamble, which clarifies many things, but it doesn't go far enough. Many of the statements in the document I certainly agree with. The last bullet here, the TVT registry has gathered data in over 100,000 patients, and the focus is in 3 new directions, and I want to reference each of these directions. 1, emphasis on direct measures of quality of care. 2, emphasis on the care of all patients with aortic valve disease rather than only those receiving TAVR. And 3, emphasis on the incorporation of shared decision-making processes. In that document, they speak to 4 phases of TAVR: an early investigative phase, an initial rollout commercial phase, and then a commercial steady state, which is, I guess, where we are now, and a mature state by 2025. The narrative from the consensus document makes good sense, with clear goals to rely on quality metrics rather than crude site volume thresholds to determine TAVR and surgery performance and site readiness as a new or existing TAVR center. The main difference in opinion is the need for acceleration in timing to the quality metric platform without a burdensome and arbitrary increased volume transition period of 7 years, which will limit patient access. So these last 2 phases, the steady state and mature state, should be combined, as TAVR has already demonstrated excellent outcomes at the current NCD volume thresholds. Direct measures of quality of care alluded to in the consensus document. They should begin immediately with direct quality metrics using a database which is already here, the TVT database. You could look at raw in-hospital mortality outcomes compared to national benchmarks, risk-adjusted outcomes, specifically in-hospital and 30-day mortality as a start. You can evolve over time to other validated outcome measures, including composite endpoints, including quality of life. The methodology has already been developed for surgery outcomes with the STS database accounting for low-volume center statistical considerations. They've been doing this for a decade. In fact, there's a significant published literature on how to deal with the lower volume sites from the standpoint of statistical adjustments. This is a complex slide. It speaks to the issue that outcome thresholds and not volume thresholds will lead to better patient care. I want you to focus on just the left panel. If we look at the data that we currently have from 2016 from MedPAR, and we look at centers now imposing a 50 TAVR, 30 SAVR threshold in pink, which you can see there, 43% of the currently practicing centers would no longer be practicing. 16% of the patients who receive TAVR would not receive TAVR. But what would be the impact on the overall mortality? We're going to go through all of this trouble to try to adjust the volume thresholds. Well, the mortality would go down from 2.0% to 1.98% by making all of these adjustments and increasing volume threshold. Second point, emphasis on all AS patients and therapies. So all forms of treatment should be available and offered to AS patients, including TAVR, surgery, medical care, palliative care, as appropriate for the clinical circumstances and directed by a multidisciplinary heart team. Everybody in this room should feel that way. The dilemma of SAVR-only centers in the US, which is the 600-pound gorilla in this room that nobody wants to talk about, which is currently 1/2 of all AS AVR treatment centers, creates caregiver and referral biases resulting in disparities in optimal AS treatment. Increased volume requirements will further limit patient access to TAVR as a treatment alternative at a time when the aging population and expanded clinical indications will demand more, not less, access to TAVR. Decreased access to TAVR will result in prolonged AVR treatment wait times and geography-based constraints which will negatively impact AS outcomes. This is data, again, from the MedPAR database, demonstrating that in the surgery-only centers, that the annual mortality, was 6.7%, and in centers where TAVR and surgery were available, the surgical mortality was 4.4%. By having TAVR at a surgical hospital, it reduces the surgical mortality substantially. This is a slide showing the impact of waiting, increasing wait times, which is common in many countries, including Canada. This data from Chris Malasry from Northwestern indicates that in the third quartile, up to 5.1 weeks, if you don't do a procedure, 4% of the patients will die. If you wait to 3 months, that number climbs to 10%. And if you look at the Canadian data, which are almost identical, an additional 15% of patients will be admitted to hospitals for heart failure. So you limit access and increase wait times. For whatever reason, these are the outcomes you can expect from a public health standpoint.
Dr. Leon, please wrap up.
Okay.
Thank you.
A systematic review of the association between patient travel and travel distance and healthcare services has been done, indicating that distance decay is important, and this association was present in many studies across a wide range of technologies. I think we all care about the patient in this room. I want to speak to the last point, which is shared decision-making. The profound influence of a shared decision-making process and declared communication aids is now being embedded into the patient management discussions, informed consents, FDA approval, clinical trials, and CMS coverage determinations. Some seminal work's been done by Megan Coilwright, who you'll hear from, where the appropriate questions are asked of patients as to what's important. It struck me that aortic stenosis patients didn't care as much about staying alive or reducing symptoms, but cared a lot about maintaining independence and the ability to do a specific activity. So the concept of shared decision-making becomes distorted in an environment when patient access to all therapies is further limited, especially a therapy like TAVR. Currently, the high prevalence of SAVR-only centers for AS is problematic for shared decision-making. And in the future, if this is to be coveted, then the goal must be to reduce SAVR-only centers for the treatment of AS patients. So the consensus document thoughtfully addresses the need for quality metrics, patient access to all AS therapies, and shared decision-making processes. However, arbitrary implementation of increased volume requirements and the delay in introducing quality metrics are counter to the above-mentioned principles. The limitations in access to TAVR will create a distance decay, delayed wait times, and will serve to worsen clinical outcomes, and shared decision-making will be eroded by available therapy disparities. So I want to conclude by offering a compromise from the standpoint of AVR volume recommendations. In the spirit of maintaining and hopefully improving both patient access to all therapies and achieving optimal clinical outcomes for all AS patients, clearly, quality metrics should supersede arbitrary volume thresholds as a general principle. We feel that surgery volumes, in fact, can be eliminated as a criteria for new and existing TAVR centers, and they should be replaced by a quality metric such as having and maintaining a 2-star rating defined by the STS. PCI volume should be decreased, although we need to have an infrastructure from the standpoint of skills to be able to perform PCI. TAVR volume should be maintained at the current NCD levels of 20 cases per year or 40 over 2 years to maintain necessary infrastructure and skill. The reasons to justify maintaining these volumes are that we've already seen excellent clinical outcomes.
Dr. Leon, you're out of time. I'm sorry. Can you just hit high points, please?
Okay. Last bullet. A TAVR quality metric should be integrated in the proposed new NCD to rapidly replace the need for volume requirements and to more closely monitor the clinical outcomes of all TAVR centers, especially the low-volume centers, with corrective measures for poor performance installed as needed. Thank you.
Thank you very much. Again, apologies for interrupting people, but we have to stay on time. And next up is Dr. Aaron Horn, who's a structural interventionalist and a board member of the Association of Black Cardiologists. Good morning.
Good morning. Thank you for the invitation. Again, I'm here as a representative, a board member of the Association of Black Cardiologists, and as a co-chair of the Structural Heart Task Force for the Association of Black Cardiologists, which was actually implemented 3 years ago when some of the data that you saw previously from the TVT registry showed that over a 5-year period of time, there was still only a 3.8% penetrance of this particular technology within the African American community. So we've spent a significant amount of time researching this, and think it's incredibly important that you are giving us a platform to discuss this today. I have no conflict to report. So when we look at the question that, one of the questions that I was asked to address is, again, whether or not there are unintended barriers to access created by volume requirements. The simple answer to this is yes. And I think that it's important to be a little bit provocative with this because oftentimes, and again, with the mission of the Association of Black Cardiologists is health equity. We have an opportunity, I believe, today to prevent being able to go down this path again and talking about unintended consequences. By looking at the data critically, I think we have an opportunity to not go down that same path. So, do hospital volume requirements create unintended barriers to TAVR? Again, there's limited evidence supporting specific volume requirements as we've seen today. Volume requirements create barriers to access for undertreated populations, as I'll demonstrate in my talk today, especially minorities, and focus should be on broadening appropriate access. So today I'll go through some of the literature in discussing and understanding access to valvular heart disease treatment and existing disparities. We'll talk about the impact of volume requirements, and again, I think most importantly, we'll discuss solutions to providing TAVR access to underserved populations. So disparities exist in a range of different areas: race, women, elderly, community versus academic centers, and geography. So we have one study that's reported lower severe stenosis prevalence in African Americans with significant limitations. I think that one of the things that we see when you critically evaluate the data is that there's clearly underdiagnosis and undertreatment of aortic stenosis within the African American community. I have some data that I'll demonstrate later, and if you look at the way in which this information is amassed, it's critically important. We know that there has been limitations to long-term care relationships within the African American community specifically, and we know that also if you look at patients that are in long-term health care facilities, you see that actually there is an increased prevalence and an increased diagnosis if those patients are actually having an opportunity to be in a sustained environment. So again, we'll go through each of these articles, but we know that existing disparities to TAVR access are well documented. Here's a study that was published by Dr. Ben Rodriguez, and he looked at, again, a retrospective cohort design of 4 community-based hospitals, patients greater than 40 years of age with aortic valve disease from January 2011 to June of 2016. And after adjusting for clinical and echocardiographic variables, black patients were less likely to be referred to cardiothoracic surgery for treatment of aortic valve disease than white patients, and the adjusted odds ratio for CTS referral was 0.48 for blacks compared with whites. This, again, was a publication by Dr. Waxman, and despite an overall increase in referrals for TAVR, blacks are still less likely to be referred for treatment. And this is, I think, again, very interesting information. Again, if we go back into the FDA approval in 2011, and even if we look at, again, the fact that now that we've gone from inoperable and high-risk patients being able to be treated via the guidelines, and now even with the intermediate-risk patient populations being able to be treated, and even, I think, we have an opportunity to improve on this, but even with more familiarity with this disease process, African Americans are still treated less likely. So if we look at, again, racial disparities in TAVR implantation, results from multiple complex factors. And this is a topic that I think we really, hopefully, the panel, we have an opportunity to discuss, because oftentimes when we talk about health equity, I think it's important to not hopefully be paralyzed by the fact that it is a complex issue, but I would argue to try to be creative and try to find solutions so that, considering the high mortality associated with this particular disease state, this is something that I think does need immediate attention. So aortic stenosis impacts all races. So based on limited data, prevalence of aortic stenosis does not vary by ethnicity. However, African Americans are at increased risk for earlier onset of aortic stenosis, hence becoming symptomatic more quickly. And we saw the Braunwald and Ross curve and how these patients can very quickly fall off that curve, and again, it results in death. We know that about 78,000 African Americans at risk of severe aortic stenosis in the United States. So aortic stenosis impacts all races with little variance. And again, this is a very important slide, because what happens is, if you look at this particular document, we know that actually African Americans in the hospital settings have been less documented to have aortic stenosis based on a physical exam or based on their interaction with the particular healthcare providers. However, if you look at objective data such as echocardiographic findings in African Americans, Hispanics, and white men and women aged greater than 60 in a long-term health facility, again, these are patients that are in a captive environment, and you follow and do echocardiograms of these patients, they actually have just as high of a prevalence, even if they might not have had an opportunity to interact with a long-term health provider over time, to be able to have that documented in their medical record. However, when you have them in a long-term healthcare facility, they actually have just as high a prevalence of aortic stenosis. However, we know again that African Americans are at increased risk for earlier onset of aortic stenosis and become more symptomatic quickly. And obviously, most important, and clearly all of the presenters today have made the focus of this the patient. The critical nature of this particular disease state means that these patients obviously have increased morbidity and mortality, and there's obviously increased costs associated with becoming more symptomatic more quickly and having increased hospitalizations and emergency room visits for heart failure exacerbations and the like. So again, it's another trial that Dr. Shaker et al. Looked at a cross-section of healthcare utilization project, aortic stenosis inpatient discharges greater than 50 years of age from 2002 to 2012. Blacks were thought to have a lower prevalence of aortic stenosis compared with whites based on patient records. But again, this is incredibly important. Based on clear objective data, based on echocardiography, the prevalence was parity. So the discrepancy, again, may be underdiagnosis of aortic stenosis in African Americans. African Americans historically have been undertreated for valvular heart disease, and again, I think this is important because obviously this is not just in the aortic valve space, but also in the mitral valve space. If you look at this particular trial, we saw that about 1,400 adult patients who underwent first-time isolated mitral valvuloplasty or mitral valve replacement in 2 institutions between 1993 and 2003. You can see that African Americans were less aggressively treated. We also know that, and this is a very important slide. If you look at the lower rate of aortic valve replacement in African Americans and low-income groups, this is a single urban tertiary care referral center, retrospective case control study, 67 TAVR patients with severe aortic stenosis matched to controls with TAVR. Non-blacks were significantly more likely to receive TAVR than blacks, and income disparity was also significant. So for every $1,000 increase in income, a 0.9% increase in the odds of receiving TAVR. I'll show you some data a little bit later, and if you look at, again, the Medicare patient population, and there's a staggering difference in the median income of African Americans compared to their Caucasian counterparts, and there's also a more striking disparity as it pertains to savings. And when we talk about, again, patients' ability to be able to access TAVR sites outside of one's particular community, cost is obviously associated with that as well. And so I would argue that this has further exacerbated this particular issue, and it's something that, again, I'm happy we're having an opportunity to discuss today. So this is, again, was my foray into TAVR. I happened to be in that first wave of structural heart fellows to come out of training, and it was striking to us when we got this particular data that showed that only 4% of African Americans, 3.8% to be specific, were actually penetrating the transcatheter aortic valve technology. And this is why we spent a significant amount of time trying to bring light to this particular issue. So low TAVR growth among African Americans. Again, TAVR penetration and growth in African American patient population remains low. And it's part of this topic has been frustrating because it's challenging at times to have to disprove a narrative that we don't see founded in terms of whether or not there's truly a underpenetration of aortic stenosis amongst African Americans. And I'll show you more data that hopefully is more compelling, that while I hopefully have already demonstrated that we see that there's an underdiagnosis and undertreatment of aortic stenosis in the African American population, it's also interesting to note that there's a higher refusal rate of this particular technology within the African American population. So when we talk about disparities that exist, I think that it's important that we talk about the full array of this particular topic as it pertains to disparities. So Medicare beneficiaries will become more diverse as patient population demographics change, and that obviously information was revealed earlier as well. So I think that what's really important, and again, this is true in the surgical literature as you'll see here, but also in the transcatheter aortic valve replacement literature, that even though African Americans have been underdiagnosed and undertreated, once they actually get to the therapy, the outcomes are just as good. So this is a very important point that, again, in this era of hopefully shared decision-making and health equity and ensuring that patients are aware of the array of technologies that are available to them, that if they actually get offered the therapy and accept it, they do just as well. So again, the first slide that I just showed was the surgical outcomes, but even if you look at transcatheter aortic valve replacement, and this is also from Dr. Waxman, that if they actually get referred, their outcomes are just as good. So reducing access to TAVR has a disproportionate negative impact on women as well with severe aortic stenosis. If you look at this particular slide, women benefit more from TAVR than SAVR. And again, in my earlier slide, that the disparities exist not just as it pertains to African Americans, but it pertains to women, as it pertains to regional variations of where people live in rural environments, et cetera. So this is also something that I hope that the panel will review as well. So patients, and Dr. Leon actually showed a similar slide about this, patients over 65 years of age avoid traveling for care. When presented with a 1% increase of death 75% of patients would still prefer their local hospital. So that's pretty powerful. Obviously, especially as it pertains to shared decision-making, patients obviously deserve that autonomy to choose, again, what's important to them. And the question is, considering the high mortality associated with this particular disease state, does it make more sense to, as we've shown with a 1.5% projected mortality risk associated with this procedure, does it make sense to not offer that patient an opportunity to receive this particular therapy when clearly they state that they're not willing to travel for their care? So patients, again, reiterates this, 20.3% of their decision to seek surgical care was decided by travel time. It's not an insignificant thing. Patients, a lot of times it's the hospital in which their children were born. This is the community that they know. This is the place that they feel safe and comfortable. And again, in this era of shared decision-making, those are all incredibly important factors that I think we have to take into consideration. So this was also shown earlier in a different variation. Time between diagnosis and treatment is greater for TAVR patients. In 2016, days between aortic stenosis diagnosis and treatment for SAVR versus TAVR. And you can see there's a 134-day difference between diagnosis and treatment for a disease state, again, that had a 1-year unadjusted mortality of 50% not treated. Number of visits between diagnosis and treatment, again, is greater for TAVR patients. 11 additional visits are typically seen for TAVR patients as opposed to patients that are offered surgical aortic valve replacement. So if we look at, again, this higher volume requirement, it can negatively impact select rural communities. With a 50 TAVR and 30 SAVR annual volume requirement scenario, there'll be 10 sole community centers that will be under the volume thresholds. So this potential for 10 communities to be left without access to appropriate therapy is very profound. And again, our membership base within the Association of Black Cardiologists treats patients in Jackson, Mississippi, Pensacola, Florida. I mean, these are real communities. These are real patients, and I hope that this is something that we continue to discuss. If we look at, again, aortic stenosis patients do not do well with waiting. If we look at, again, in the interest of time, this is a slide that we went over previously, but you can see that this is a particular disease state with a very high mortality associated with it. And hence, again, under the current iteration, we see that patients that undergo TAVR evaluation wait 134 days more, 11 more visits. This is something that we hopefully can figure out how to streamline as well. And we look at, again, the 1.5% TAVR in-hospital mortality in 2017. So impact of volume requirements. Volume requirements would heighten socioeconomic and racial disparities. And this is, again, a different study. And I hope that what's reassuring, because obviously the point here is to only address evidence that's here in the literature, and you can see that in the lexicon literature on this particular topic, there actually is a significant amount of information demonstrating the issue that we're trying to address here. So again, for every $10,000 increase in income, the odds of receiving TAVR is increased by 10%. And non-blacks were significantly more likely to receive TAVR than blacks, with an odds ratio of 2.812. And so this is the slide that I alluded to earlier. If you look at the minority Medicare beneficiaries and the less economic stability to overcome additional barriers to access and healthcare services, if you look at, again, the median per capita income of Medicare beneficiaries by race, ethnicity in 2016, you're talking about $30,000 for whites and $17,350 for blacks and $13,650 for Hispanics. And again, the median savings, which is incredibly important, you have a difference that's, eightfold. And so this disparity is something that we can't ignore, because we know that obviously economics are going to influence patients who are consumers in the healthcare space decision-making process. And the way in which we are currently constructed, this is something that these patients are still having to deal with. So a few hospital programs will meet the proposed advanced center of care volume thresholds. And again, this is an acknowledgement that this slide does not reflect the consensus document that was discussed earlier today. And this is an older iteration that was a consensus document regarding centers of excellence. So again, want to acknowledge and clarify that. However, if you looked at the requirements that were previously suggested, only 10% of centers would meet all three of these volume requirements. And therefore, you have a disproportionate amount of patients that wouldn't have access to what is clearly a life-saving therapy. So, volume thresholds could significantly reduce the number of hospitals providing valve services. So again, if you look at the reduction in the number of hospitals providing valve services from 1,135 in 2016 to 119 after the imposition of thresholds, this would be the environment in which patients would have essentially deserts of places where they could receive care. If you factor into the fact their preferences or lack of preference to travel and the economics surrounding their ability to be able to get access to said care. So most importantly, what are the solutions? So this slide is incredibly important, and I hope is something that we can reflect on a little bit. What I think is most important, if you look at, again, patients' reasons for not undergoing aortic valve replacement, you can see here that you have a disproportionate number of patients in the African American community that actually decline this life-saving therapy. At the least, I would argue that would posit the rationale for some self-reflection. And I think it's multifactorial. Travel is clearly a piece of it. Education is a piece of it. I think that at least what I would hope is acknowledgement that that's something that we need to delve into a little bit more. So we looked at, again, from the Journal of Racial and Ethnic Health Disparities, that after echo, blacks were more likely to decline AVR, be lost to follow-up, and to not be referred to cardiology. So again, this is from the American Journal of Cardiology, and this is something that I mentioned earlier. But again, after adjusting for clinical and echocardiographic variables, black patients were less likely to be referred to cardiothoracic surgery for treatment of aortic valve disease compared to their white counterparts. So potential solutions. I would argue that existing geographical barriers would lead us to think about geographic alignment. If we look at counties where 20% or more of population is African American and focused on centers in those particular areas, then one would argue you'd have a better opportunity to, again, get care to the patient as opposed to putting the onus of the patient to go to where treatment is available, considering other variables such as cost and comfort and preference that are currently limiting patients' ability to seek this particular care. This is obviously, again, a very, very important article, and this was mentioned earlier that it's critical to this discussion. However, I would argue that some of this data was based on earlier iterations of the valve when you had larger sheath sizes and you didn't have developments as it pertains to abilities to decrease paravalvular leak and things along those lines with the technology. So, solutions. I would argue again that there needs to be a frank and honest discussion and acceptance of a need to improve in this particular space. Three potential opportunities are to conduct patient outreach survey, patients receiving TAVR and those who refuse treatment. I would recommend developing a TAVR advisory board, partnering with the Association of Black Cardiologists to increase education and awareness, and develop a national campaign to address disparities. So this is my experience. In Dallas, Texas, and I came to a center which is not dissimilar from a lot of other centers in Dallas. However, if you look at the median U.S. income is $57,000. If you look at Dallas, it's $47,000. In Oak Cliff, where I practice, is $41,991. So during the period of time that I've been there, we actually have performed. This was presented in May, so we're up to about 60 now. And in that period of time, 28% of our patients happen to be African American, 4% is the national average. So I would argue that this is not insignificant, and clearly there's an opportunity to do a better job of penetrating this particular demographic, as we've shown in our smaller community-based hospital, that's been what we've accomplished. And you can see, proud of the outcomes that we've had, and this is something that clearly is a single center case study, but I think it's indicative of the opportunity to improve. And note that if you look at just the stark difference in the penetrance of African Americans that we were able to treat based on, in comparison to the national data. So implications and conclusions, I think we need to reconceptualize hospital metrics. Shared decision-making is not optimal unless all valve centers offer both SAVR and TAVR. Limiting patient access through arbitrary procedure-specific quotas will create unintended barriers, and hopefully we have an opportunity to prevent those barriers from being unattended. Transparent quality metrics is how programs should be differentiated. We need to build greater understanding and awareness, develop greater understanding of patient barriers to TAVR, use that information to inform awareness campaigns directed towards patients and physicians, and plan for community TAVR centers and novel outreach, align TAVR centers in communities where need is greatest and population is underserved. Thank you for your time.
Thank you very much, Dr. Horn. It is 10. We are 14 minutes ahead of schedule, so thank you to all the speakers for that, for being crisp and concise. So the break is moved up. It's going to end at 10:31. We'll be back in our seats. A couple of housekeeping announcements. I've seen a number of my friends from the press in the back, particularly. There's a separate sign-in sheet for people from the press, which is currently blank. So may I ask that you sign in on that press sheet? Don't be ashamed of your profession. As regards to the press, we are all private citizens on this panel, but we will not speak about the topic of this MEDCAC in the halls. Many of us are friends with people in the audience. We're happy to socialize, but we will neither speak amongst one another, nor with the press, nor with anyone here during the breaks or lunch. Afterwards, we are all free to do and speak with whomever we'd like. Thank you very much for your attention this morning. Wait till you have a mic. Okay, Robert, these two. The other housekeeping, David Cox and Robert, I can't, Robert who writes like a doctor, Subedu?
No, we have David's. We need
Oh.
Tom and Robert.
I'm sorry, Tom Nguyen and Robert Subedu write like, could you please see Maria about disclosure issues because you're signed in to be a speaker. Thank you, Dr. Feldman. You have 5 minutes.
Thank you very much. I'm Ted Feldman, representing the Society for Cardiovascular Angiography and Intervention. I'm a past president of the organization and an interventional cardiology practitioner in a medium-sized community hospital. I've been involved with PCI for over 3 decades and TAVR since its inception in trials here in the United States. This is my disclosure statement. First, I want to say on behalf of the Society that we endorse the Multi-Society Expert Consensus Systems of Care document. And I want to emphasize 2 points. As a practicing interventional cardiology and TAVR operator, I am confident that a PCI volume threshold is important to both begin and sustain TAVR programs. Expertise in PCI is critical not only to the ability to handle the not uncommon catastrophic complications of TAVR procedures, including coronary occlusion, but also the complex concomitant coronary artery disease that requires treatment ahead of these procedures in at least 20% of cases and commonly afterward. And I also want to emphasize that the Society is confident that procedural volume requirements for TAVR programs outweigh the harms of limiting access to TAVR to only hospitals that meet these volume requirements. We are confident that we have identified a volume outcome relationship with TAVR, as has been demonstrated with virtually every other complex procedure in medicine, and we remain unconvinced that there's an access to care issue that would be resolved by the addition of more TAVR programs. I want to say further that the individual operator and institutional requirements may be less important than the aggregate of these requirements that we believe define institutions that have the physician resources, the institutional infrastructure, and the capability to deliver highest quality TAVR services. I want to also take a minute to emphasize that the multi-society effort to promulgate a set of recommendations to optimize quality care for patients represents the real ideal of professionalism. And I want to reference a document that defined professionalism here and note that this has been a collaborative work among 4 societies representing the majority of interventional cardiologists and surgeons in the United States, and that this is the best of a process for self-regulation and standard setting, and that the goals of scrutiny and transparency in the document are really critical. We do believe that patient and physician education are the most important elements to improve access to care. And I think several of the prior presentations emphasize that the barriers to access are actually complex and multifactorial. And I want to emphasize one data point I've seen in the discussion of this issue over the last several months. In the state of Wyoming, which has 0 TAVR sites, the rate of TAVR per Medicare population is significantly higher than in my home state of Illinois with 19 TAVR sites. It's very hard when you see those data to argue that adding sites in Illinois is going to improve the access to care rather than working hard to educate patients and physicians regarding this disease. And I would say that a lot of the growth of TAVR that we've seen in the last half decade represents existing efforts to promulgate education and educate both patients and physicians. So we do remain focused on quality, and I think a couple of the next speakers are going to talk about how difficult and critical it is to measure quality. But the idea that access and more sites are equivalent, I think, has been a big part of the discussion up until now, and there is absolutely nothing to suggest that those two things are equated with one another. Thank you.
Thank you, Dr. Feldman. Next up is Dr. John Carroll, who's a professor of medicine, University of Colorado School of Medicine, representing the American College of Cardiology, and thank you for coming.
Thank you. My name is John Carroll. I'm a clinical interventional cardiologist. I treat patients with valvular heart disease, and I do perform TAVR. These are my disclosures. I'm salaried. I volunteer my time to ACC. The STS ACC registry is a new model of collaboration among many stakeholders. Could I have my slides?
I'm sorry.
G. Carroll. Thanks. So this is a new model of collaboration among many stakeholders, and we agree on much more than the disagreements that have been aired today. The registry has multiple critical functions, creating a clinical knowledge machine, developing metrics for high-stakes applications, providing the infrastructure for aid to regulatory and reimbursement colleagues. Did the original NCD succeed in its purpose of rational dispersion of a new treatment? The huge growth in TAVR is related to the treatment access at 584 sites, and the professional consensus document does not close those sites, as has been thought by a draft. And the U.S. has the highest density of TAVR sites anywhere in the world. The excellent clinical results in the U.S. cited by many today have occurred in the context of the original requirements that include volume thresholds. That should go into the decisions of the committee voting on these volume requirements. These data from DCRI have been explained by Dr. Bavaria. These are contemporary data combining S3 and Evolut. If you separate out them, you lower the power of your statistical ability to determine differences. But clearly buried here in the overall improved outcomes is a signal that low-volume sites have a great variability. Yes, some have zero mortality, but you want to go to a site that's done 10 cases with zero mortality? These outcomes are apparent with a 50-case threshold, and reducing the proposed requirements would be expected to create a large increase in the number of low-volume sites. So, Dr. Leon, you want to marry low-volume SAVR sites with low-volume TAVR sites and low-volume TAVR sites with higher surgical mortality? No. As individual outcomes have improved, it increases the need to use composite outcomes to assess site performance and its relationship to volume. These recently acquired concerning data argue that it's premature to discard considerations of volume thresholds. We acknowledge that there are issues of access to TAVR due to patients not being told about TAVR, and we need to correct that, not by opening more sites, but by education. We acknowledge and concerned with broad healthcare disparities based on rural locations, race, et cetera. And we'd love to partner with Dr. Horn in addressing most of those issues that have nothing to do with opening more TAVR sites. They're basic healthcare, education, and access issues. The TVT registry does gather data on reported healthcare outcomes, pre and post TAVR, and we're developing predictive models of patients at 1 year being both alive and with an improved quality of life. This is groundbreaking work that must be continued. The NCD must be continued with its emphasis on coverage with evidence decision if we want to continue to learn and solve many of these questions that have been raised today in a scientific way and come up with the right solutions. TAVR is not a simple procedure. 22% of patients undergoing TAVR have significant in-hospital procedures. It's not like simple hernia and should be distributed to all hospitals. The need for a PCI threshold is not related to a volume outcome relationship. It's related to the experience and expertise to treat patients with severe AS and coronary disease. The need of a surgical AVR threshold relates to having high-quality TAVR as an option for patients to select and having surgical experience and expertise for the multiple TAVR-related issues, and 6% of TAVR procedures still require surgical access. And I'd like to point out that Dr. Leon actually agreed in his compromise with the need for some volume thresholds. In conclusion, the transition to using sophisticated quality metrics to assess site performance has begun. Your voting to support certain volume thresholds during this transition will protect patients and allow a large family of high-quality programs to continue to grow and fully mature. Metrics for performance assessment do not magically appear. They require much work to develop and validate from independent experts in health outcomes research. An accreditation process must be also developed. And I employ the MEDCAC committee not to discard any consideration of volumes. You're not to vote on absolute numbers, but whether there should be any volume thresholds for programs to open and continue. The unintended consequence of reducing standards, volume thresholds, is straightforward. It is to compromise the quality of care for all Americans, rural, African Americans, etc. Thank you.
Thank you, Dr. Carroll. Next up is Dr. Shahian, I hope I'm pronouncing your name correctly, who's a professor of surgery at the Harvard Medical School. He's a chair of the Society of Thoracic Surgeons Council on Quality, Research, and Patient Safety. Dr. Shahian.
Thank you and good morning. Well, you've heard, or you will hear from other presenters, that volume thresholds are simply an inferior proxy to direct measures of quality, and that they should be eliminated. Quite to the contrary, we believe that volume thresholds are an absolute prerequisite for accurately measuring direct quality. No organization in healthcare has demonstrated a greater commitment to quality measures than STS, as evidenced by our largest in class number of NQF endorsed measures, most of which are risk-adjusted outcomes. 65% of our adult cardiac surgery participants publicly report these on our website. Note both risk-adjusted and morbidity and mortality for aortic valve replacement, as well as several process measures for CABG. This slide from our manuscript shows that we are developing a similarly robust portfolio of direct outcome measures for TAVR, and will also institute a public reporting system. So, given this commitment to direct quality measurement, especially outcomes measures, why volume thresholds? Why are we supporting this? Well, one reason is the Volume Outcome Association, shown by Dr. Carroll and others today. But there's another critical reason. If we want to accurately and reliably measure quality, we have to address three fundamental measurement issues: random sampling variation, measure reliability, and the statistical power to detect outliers. This slide depicts the 95% confidence intervals of a proportion or a rate at various sample sizes corresponding to program volumes. If you take a sample, let's say a year's worth of cases, that has only 50 or even 100 procedures, and you get a result of 3% for mortality, the real underlying mortality rate of that program could be anywhere from 1% or less to 8, 10, or even 12%. Now, you remember those very low volume programs in previous slides that some presenters described as being high quality, low volume programs? Well, the fact of the matter is, and they know this, that we know absolutely nothing about a program that does 30 or 40 cases and has 0 mortality. They could easily have 10 mortalities in their next 50 cases and have an overall mortality of 10%. This slide shows a related concept, prediction intervals, which are the basis of funnel plots, which we and others use to assess quality. If we know the average rate in a population, say about 2%, as in this slide, prediction intervals show you the range of sample values, again, let's say a year's results, from individual providers that would still be consistent with that program having a rate that's not statistically different from the population average at whatever confidence intervals you choose. Again, you can see that at volumes of 50 or 100 cases, sample values of 10% mortality could still be perfectly consistent with a true underlying mortality rate in the long term of around 2%. So, 2 different statistical techniques, but the same message. Small samples, low volumes, substantial random sampling variation. Another fundamental characteristic of a good performance measure is reliability, signal-to-noise ratio, reproducibility, which for all STS composite measures, we require to be at least 0.5. In this example, which is taken from colorectal surgery, where the event rate here was 20%, below volumes of 100, that is to the left of 100 cases, reliability is consistently well below 0.5. And if you take even lower event rates, the kind that we're talking about here with TAVR, that reliability would even be much lower. So we have no reliability really to speak of at the kind of volumes that would occur if we didn't have some kind of volume threshold. And finally, the power to detect true outliers is highly dependent on sample size. As shown in this slide, for a procedure with about a 3% mortality rate, to detect a doubling of mortality with an alpha of about 0.05, you'd need hundreds of cases to have 80% power, which many regard as desirable. The smaller the sample size, the more likely you are to have a type 2 statistical error, failure to identify a true difference in performance. In summary, outcome measurement is highly problematic with low volumes. If we're truly interested in assuring high-quality TAVR, then programs have to have sufficient case volume to allow meaningful quality measurement. Frankly, if I had my way, it wouldn't be 50 cases, it'd be 100 cases, because I think both the volume outcome data and the statistical considerations are much more convincing at a level of 100, but we'll settle for 50.
Dr. Shaheen, please wrap up.
Sure. And just in case some of you are wondering, well, how do we deal with this in the case of STS performance measurement? For our composite measures, they have much more ability because they encompass many different kinds of outcomes, much greater ability with fewer cases to detect differences in outcome, and we do require a reliability of 0.5 for every measure. Thanks very much.
Thank you very much. Next up is Dr. Thoralf Sant, who's the Chief of Cardiac Surgery at the Massachusetts General Hospital. And please, may I ask, please try to stay on time. There's a clock here to the right, so you can monitor yourself.
All I need is my disclosure slide. My name is Thoralf Sant. I'm Chief of Cardiac Surgery at the Mass General Hospital and Professor of Surgery at the Harvard Medical School. More importantly, I'm a clinical heart surgeon. I've practiced cardiac surgery for more than 25 years, and I frequently care for patients with aortic stenosis. I appreciate the opportunity to address the panel. We're here because transcatheter aortic valve replacement has been transformative. We celebrate this advance, we embrace the technology, and welcome the innovations that make it more technically reproducible and accelerate the learning curve. As the technology came online, CMS wisely recognized that access to high-quality care demanded rational dispersion of this powerful technology. The NCD has had a very, very positive effect by reinforcing the importance of the multidisciplinary team. The issue at hand here is broader than the ease with which a device can be implanted in an aortic annulus. The issue here is the treatment of aortic stenosis in human beings. The Institute of Medicine established patient-centered care as one of the 6 dimensions of healthcare quality. This requires informed discussions of all options. Only when all options, including surgical aortic valve replacement, are available with high-quality outcomes can truly patient-centered care be provided. Care in which the treatment is tailored to the patient rather than tailoring the patient to the available treatment. A functional heart team is critical to providing this care, especially to the most vulnerable patients, those patients least empowered as their own advocates to navigate the complexity of the medical system. We want to very directly address the specific questions you have posed. Drs. Feldman and Carroll have focused on TAVR, including, importantly, the variability in outcomes among low-volume centers, and Dr. Shahian has discussed the inescapable challenges in proving quality when numbers are small. As a representative of a surgical organization, I will address your questions specifically surrounding the surgical requirements. You asked us about the requirements for initiating a TAVR program. Specifically, how confident are we in the surgical volume thresholds we've set? The answer is very confident. We all strive to be evidence-based. Still, there are few randomized trials in the treatment of valvular heart disease. Accordingly, we rely on collective experience and judgment. Surgical aortic valve replacement has been performed for almost 60 years, with a decline in operative mortality rate currently to 2%, according to the STS database, not 4%. The cumulative experience of the surgeons on the writing committee exceeds 200 years of clinical experience in the centers to which patients with failed operations are referred: Stanford, Penn, UCLA, Pitt, Michigan, Emory, Harvard. It's the view of this group, as I suspect it is for many of you, and I guarantee is the view of the patients I see every day in my office prior to undergoing heart surgery, that teamwork, experience, and practice matters. How often am I asked by a patient, how many of these have you done? And how frequently do you do this operation? And do you work with the same team regularly? These are appropriate questions, as evidenced by Dr. Leon's demonstration of the relationship with outcomes and surgical volume. Thank you, Marty. The number set in this document is just shy of a week, one a week for a new program. Not an impossibly high bar by a long shot, less than one a week. You also ask us the closely related question, how confident are we in the threshold of procedural volumes for the principal cardiovascular surgeon? The answer is very confident. The learning curve for many surgical procedures has been studied and published. It's remarkable how often the number 100 recurs. This is required to safely and reliably achieve the high-quality outcomes our patients deserve. Remember, these are also the surgeons that will be called on to rescue patients from the uncommon but potentially catastrophic complications of TAVR. This is particularly important in institutions starting up their TAVR programs where the complications may occur more frequently, and especially as the move to lower and lower risk patients occurs. The annual volume threshold is less than twice a month. Again, not burdensome. How confident are we in our threshold TAVR procedure volumes to maintain a program? Very confident. The threshold recommended at a bare minimum is less than one a week. If care is to remain patient-centered, the surgeon and team must be able to offer the same access to high-quality care to the patient, more appropriate to undergo surgical aortic valve replacement. In conclusion, the AATS believes that it's critical that CMS continue to support the value of this multidisciplinary approach. It's about ensuring access to high-quality patient-centered care. We've heard the analogy to pediatric cancer care. That this care is provided in only specialized centers has nothing to do with the ability of the pharmacy to mix the drug, and it has nothing to do with the ability of the IV team to conduct the infusion. It's about the experience and judgment of the whole team. We all know that care is best provided by teams with experience and teams that work together frequently. The team needs to keep sharp, and like any technical exercise, whether playing the violin or performing heart surgery, experience matters, and so does ongoing practice. Isn't that where you want your care? Thank you.
Thank you very much. Next up, Susan Strong and Danette Smith are presenting together. They're both heart valve survivors. Susan Strong is the president of the Heart Valve Voice US. Danette Smith is president of Mended Hearts. They collectively have 10 minutes.
Good morning. As was said, my name is Susan Strong, and I am a TAVR patient. I am also a founding board member and the president of Heart Valve Voice. Heart Valve Voice is a nonprofit organization that's committed to improving the diagnosis, treatment, and management of heart valve disease for patients. We are exclusively focused on representing the voice and priorities of heart valve patients. I am a long-term survivor of Hodgkin's lymphoma with radiation-induced heart valve disease. My valve was replaced via TAVR in 2014. For the past 4 years, I've had the opportunity to connect with hundreds of patients, and I'm grateful that you today are including our voices, in a meaningful way in this very important discussion. I hope that you'll remember this from today, that patients want to be a part in shared decision-making. We deserve to know about all of our treatment options and to have appropriate access to all of them. It's my pleasure to share the podium with Donette Smith, President of Mended Hearts. I'm now going to cede the remainder of my time to Donette, who will give the formal presentation on behalf of our task force.
Ms. Strong, just a procedural issue. You need to give disclosures verbally since you don't have any slides, if you can.
Okay, my disclosures are on our slide. Will that work?
Okay.
Okay.
They're on the next slide? Okay, great. Thank you. Sorry about that.
Thank you, Susan. On behalf of the Heart Valve Disease Policy Task Force, thank you for the opportunity to present our views on access to all appropriate treatments for all heart valve disease patients. These are our disclosures. I was born with a bicuspid aortic valve and have had 3 open heart surgeries. Every week, I'm honored to visit with patients and their families to help them as they face their treatment and their recovery. As an organization, Mended Hearts supports more than 200,000 patients throughout their journey each year. So we know the patient story. Mended Hearts is honored to partner with organizations such as the Alliance for Aging Research and Heart Valve Voice. Sue Peshin, the president and CEO of the Alliance, and Marilyn Serafini, the executive director of Heart Valve Voice, are here with us today. The mission of the task force is to advocate for policy solutions to improve access, research, and awareness of heart valve disease detection and treatment. There's no question that valve disease is deadly. Let's all acknowledge the elephant in the room. Patients die from lack of access. Sorry, my pages are sticking together. So what stands in the way of better health outcomes? First of all, awareness of the disease is low. 3 out of 4 Americans report knowing little to nothing about heart valve disease. Additionally, 6 in 10 heart valve disease patients surveyed responded that they did not have or recognize their symptoms. They were diagnosed only because they went to the doctor for something else. Y'all already know from previous speakers that as valve patients wait for treatment, we die. So our focus needs to be on getting patients more timely access to these life-saving treatments. As has been previously shared, the undertreatment of aortic stenosis is very well documented. Today, not every patient has a fair shot. When discussing treatment options, we know that even if patients qualify for TAVR, this option is not always presented. Based on multiple analyses of TAVR that were cited earlier today, significant disparities exist based on race, ethnicity, income, and actually where people live. While these disparities are not unique to valve disease, the questions behind them remain unanswered, and we need to continue to search for the why. When the original NCD was decided, volume was used to ensure quality in the absence of other evidence. Thanks to the TVT registry and numerous studies, we now have a significant body of evidence that proves TAVR is safe and effective. TAVR is an important treatment option that can reduce the burden on the patient. Not only is it less invasive, but it also improves the patient experience. It shortens hospital stays and recovery times, and it produces better outcomes. Despite good intentions, the current NCD creates unintended barriers. Choosing to use volume instead of quality as a measure may inappropriately restrict access. Typically, only the largest hospitals in the country offer these new therapies. Bottom line is, patients do not hear about all their options unless they are lucky enough to walk through the right door of the right hospital. This creates inequalities. Experiences vary greatly depending on which hospital a patient visits and which provider they consult. And frequently, the patients who are harmed are the most vulnerable in our community. Quality is what matters to patients, not quantity. In the case of TAVR, there are ample data to help patients like me make informed decisions based on our personal priorities. This panel should consider the more recent studies that have shown excellent outcomes in both high and low volume hospitals. Patients should not be put in the middle of meeting annual volume requirements to maintain programs. Additionally, outcomes that are meaningful to patients are what really matters. Depending on where a patient may be in life, certain outcomes may be more important than others. Outcomes that were important to me were how long I had to stay in the hospital, being able to recover at home, and what kind of a burden I would be on my husband and my family. For some patients, these outcomes may be even more important than survival. The Heart Valve Disease Policy Task Force believes that all patients should have access to all appropriate treatments. To achieve this goal, we have the following recommendations. First, we need to move away from volume requirements and adopt specific quality. Sorry, one more slide. First, we need to move away from volume requirements and adopt specific quality measures that matter to patients. We also need to provide patients access to unbiased, easily understood information on hospital and provider performance through a tool like Hospital Compare. Last, we need to apply the same rules to both SAVR and TAVR. Every patient deserves the opportunity for real shared decision-making so we can choose the right treatment at the right time and at the right place. Speaking as someone who has literally placed my heart in a surgeon's hand multiple times, it makes me sad when I meet patients or caregivers who would have made a different decision had they known their options. You have an important opportunity in front of you today to continue moving forward to ensure better access and hope for more patients and their families. On behalf of the patients, thank you for this opportunity.
Thank you very much. Ms. Strong? Ms. Strong? Hi, it's me over here. Hi, yeah, you have to, I'm sorry, you have to disclose your own conflicts of interest, not those of that were in the slide deck. You weren't listed on that slide, so if you don't know what to disclose, we can go over it. Or.
Okay. I have once received a speaking fee for a patient day from Edwards Life Sciences.
Perfect, thank you. Next up is Dr. Stephen Goldberg, the Director of the Structural Heart Disease, Tyler Heart Institute Community Hospital of the Monterey Peninsula.
Thank you very much. I'd like to thank the committee, and I'd like to thank CMS for this wonderful opportunity to have this debate today, and I think to provide an opportunity to air some opinions that otherwise have not had a forum for this discussion. I titled mine that this is an access of care issue rather than a volume requirement issue. I don't believe I have any conflict of interest to disclose on this matter. Volume requirements, of course, is used as a surrogate for quality of care, but access to care is the dynamic tension that is impacted by these requirements. This is a busy slide. I'm going to skip through many, many things here. But I think that we have to focus in on data versus opinion. We've already heard excellent discussions on the lack of data on PCI volume and TAVR experience. But I'd like to go down to the fourth line here and say, is there any representation from the smaller hospitals that are impacted by these volume requirements? If not, who is protecting the interest of patients treated at those institutions? And here after that is just yet another reference saying that there is controversy as to whether volume requirements, measures are accurate surrogates of quality, at least with relationship to cabbage. Assume for a moment there is a statistically significant but clinically small difference in outcome when the procedure is limited to larger hospitals compared to smaller volume hospitals. Is it not important to ensure that the drop in access to care doesn't numerically overwhelm the small difference in outcome? Why do patients go to smaller hospitals? Geography, and Dr. Pelican mentioned that even in an urban center, geography can be a major issue. Cultural, which has been well addressed by Dr. Horn, and efficiency. Patients prefer to go to smaller hospitals. This has been documented with higher satisfaction rates of patients treated at smaller hospitals than larger hospitals. It is interesting to see that the distribution of hospitals in this country, that the majority of hospitals that are large enough to provide TAVR, but are, in other words, at least 100 beds, most of them are less than the large hospitals. So the 5%ers, I think, is where most of the key opinion leaders and the opinions are coming from, but there are 4 to 5 times as many hospitals that could be providing TAVR that are in the less than 500 bed range. And if we look at who is doing most of the work, in fact, it is the operators at these smaller hospitals. From the California OSHPD, or Office of Statewide Health Planning and Development, we see that there are 16 hospitals with over 500 beds. But the other hospitals perform most of the valve surgeries on patients. So there are 3 to 4 times more valve surgeries done in the smaller hospitals. And I would ask, is there appropriate representation for these hospitals in making the decisions for CMS or for these guidelines? Consider the TAVR patients. We've heard this already. They're frequently elderly and or debilitated. Traveling carries challenges, including medical risks, fatigue, and costs. Their support system, their family members, are also affected by traveling, the time off from work, or perhaps they can't even find time to take off from work in addition to costs. The need to travel is often used as a reason not to pursue TAVR by symptomatic elderly patients. I can just share my personal experience, having just moved to Monterey, California, that is an argument made by many patients. And Dr. Horn has already talked about minority patients. So arguments, I think I'm going to skip that and this and just go to the TVT registry data, that the conclusions from the TVT registry analysis that has been mentioned, that the data is high quality and is of great interest, but is inconclusive. It is reasonable to believe that the data may not be currently relevant in light of the confounder of learning curve as part of that analysis, as well as advances in TAVR. Relying upon these preliminary data to justify public policy decisions seems to be arguable at the least. Shouldn't it be a clear message that drives public policy decisions, not, quote, way beyond the understanding skills of a vast majority of cardiologists like us, end quote? The comment from Alain Cribier, who was wrote the editorial regarding the TVT registry data. The downside of accepting and acting on these preliminary and confounded data will be a restriction to access of care.
Please wrap up.
This is it right here. So in conclusions, maintaining or establishing volume requirements limits access of care to patients with established benefits to TAVR. Most key opinion leaders come from larger hospital systems, so have a potential inherent bias and conflict of interest over this issue. Establishing a voice for smaller, less vocal hospitals, as Dr. Pelican has done today, is important in establishing major policy decisions, especially since those hospitals care for a significant percentage of U.S. patients, over 3 times the volume of larger hospitals. Thank you very much for your attention.
Thank you, Dr. Goldberg. Next up is Larry Wood, who's a corporate vice president at Edwards Life Sciences.
I'd like to thank the panel for being here today, and I'd like to thank CMS for the opportunity to speak. My name is Larry Wood. I run the transcatheter valve program for Edwards globally. Get to my disclosure slide, but Edwards pays all of my salary, and my entire existence and well-being is dependent on my job there, so you should probably take those things into consideration when you take my commentary. But I have also been involved with TAVR since the very inception of it, and it in many ways I feel like is my life's work, my purpose for being here. There's the consensus documents that have come out from the societies, and unfortunately the documents were not finalized prior to us submitting our slides, so we were all working off drafts. I think the societies have moved a long way in their preamble to try to address many of the concerns expressed by many of the stakeholders. However, there still are volume requirements in the document that we believe could adversely affect patient care. I think the evidence around that we've heard today around the volume outcome relationships, from our perspective does not exist or is not supported by the evidence. But restricting access to care, we know, will harm patients. Even increasing patients' weight to care will adversely impact patients, as was shown in a number of presentations today. Intuitively, volume outcome makes sense. Intuitively, I think everybody thinks it makes sense and we all believe it, but the question before us today is what evidence do we have to support it? And when we look at contemporary TAVR, we just don't see the volume outcome relationship with our latest technology, and I think that's true of both companies. I think that's true of Edwards, and I think it's true of Medtronic as well. When we started TAVR and we first commercialized, our first full commercial year was in 2012. And when we started it, there was a lot of questions about whether this procedure could be rolled out safely, whether it could be rationally dispersed, and whether we could duplicate the high-quality outcomes in the clinical trial sites in the generalized setting. And we started with about 100 centers, and we had a mortality rate just under 5%. We've continually added centers every year, and we have watched the results continue to improve. And in 2017, there were 540 active TAVR programs, and the mortality rate fell to 1.5%. So I think this shows that we have been able to expand, and through high-quality training and high-quality proctoring, and the entire community coming together to teach each other from their own mistakes so that new centers didn't have to repeat them, we've been able to advance this therapy in an incredibly responsible way. I think most people point to this as the best example for rolling out a new disruptive technology, not something that we need to attack or change. This is a slide. This is Medicare claims data, so this is the Medicare population. This was shown earlier, so I won't spend a lot of time on it. I think what this slide illustrates, though, is when you have two therapies that can be used for the same patient population, it's critically important that we look at those procedures holistically, not individually in isolation. It's important that patients want to know how well their aortic stenosis is being treated, not how well a center might do one procedure versus another procedure, and I think that that's critically important. Many of the experts have agreed that TAVR will likely become the preferred option for patients. I've heard people say it will be 70-30 or 80-20 would be the split, and I think that those are reasonable estimates as we go forward. As TAVR continues to shift volume from surgery to TAVR, it will become increasingly difficult for centers to meet the surgical volume requirements. What do we want in the healthcare system? We want centers to do the procedures that they can do well, and we want them to refer the procedures out that are beyond their capabilities. But when you put volume thresholds in place, you create incentives to do just the opposite of that. If a center is struggling to meet their volume requirements, they have to hold on to every single patient. They can't refer them to another center for what may be a more appropriate procedure for that patient. And this gets very real if you're a patient. This is a patient. This is a real patient that we have, but I'm using it as an example here. Let's say that there's a hospital, and in November this patient presents. He's 82 years old. He has a number of comorbidities. He would be considered intermediate or high risk. The center's done 52 TAVRs. They've met their TAVR threshold by the new requirements, but they've done 25 surgeries. This center is now faced with a dilemma. Do they do the procedure that they think may be best for this patient, or do they do the procedure that they need to do to meet their quota? And the irony of this is, in this theoretical world, if they didn't meet their surgical quota, they would lose their TAVR program, but they would continue to do surgery. And that just doesn't make good logical sense for patients. I think when we look at the system, we have to think about this from a very patient-focused perspective. And what do patients want? Patients want to get high-quality care. We have the ability to measure quality today. Things like the STS risk score is very sophisticated. We can use OE ratios. There's things that we can do today that we can measure how all valve patients do at any center, and I think that that can be done. I think centers want to make, or patients want to make sure they get the right procedure, and that means the right procedure for them as an individual. And I think they want to have that done as close to home as they can possibly do it and get high quality care, because it does create a burden on their family. The average TAVR patient goes through 10 to 15 hospital visits before their procedure, and many of these patients, the average age in the United States is 80 years old. It is a significant burden on these patients to travel distances. So with that, I will conclude my comments. Thank you.
Thank you very much. Next up is Dr. Pieter Kapetin, who's the Chief Medical Officer at Medtronic, in charge of structural heart and cardiac surgery. Oh no, I'm sorry, who's been replaced by Eric Vang, Dr. Eric Vang, also from Medtronic. Sorry about that.
Yeah, unfortunately, Peter was not able to be here due to unforeseen circumstances. Again, my name is Eric Vang. I'm the Senior Director for Clinical Research at Medtronic Structural Heart. I've been in clinical research for about 20 years and been on the forefront of a lot of the evidence development and therapies. And so with that, I do believe that the discussions that we've had today do require a strong balance between quality outcomes and patient access and be data-driven. Medtronic does not believe that there is sufficient evidence to modify the volume requirements in the TAVR NCD at this time. Obviously not my disclosures, but I am an employee of Medtronic and a shareholder as well. Medtronic has invested significantly in evidence and the procedural training for the safe and responsible growth of this therapy, as illustrated on the slide. Our analysis of the data has shown excellent outcomes under the existing NCD, and that there is no relationship between volume and outcome. We share the concerns expressed today regarding any potential decrease in the number of centers which could impact the patient access. The following slide illustrates the TVT results, which are being shared today for the first time. The TVT registry shows that mortality, stroke, and major vascular complications, and pacemaker implantation in the real-world setting in patient populations will continue to improve and have improved and are shown here to be numerically lower than our clinical trial results. This holds true across all risk stratas. You can see that with extreme risk, high risk, and the intermediate risk cohort. These are 30-day complication results, and as you see here at 1 year, they still hold true. Given today's focus, we analyzed the data from the TVT registry and the outcomes stratified by site volume, and then compared this data to our trial. While this is a complicated slide with a lot of information, the key takeaway from this slide is that we do not see a difference in outcomes across site volumes. This prompted us to conduct further analysis to understand this discrepancy. So at this point in time, I'd like to move away from the slide and like to direct the panel to a handout that we provided with you earlier today. This is also available outside of the room just as you move outside the doors. This is a handout that includes analysis that we provided the CMS earlier this week, and they allowed us to share this with the panel today. In looking at the volume-based outcome relationship, we attempted to replicate the analysis presented by the societies as it was inconsistent with our own analysis. Working with direct research, we utilized the MedPAR data. This data is publicly available claims data set which reflect the TAVR procedures performed on Medicare patients. Please refer and look at the top of the page 1, the first slide. We believe that the society analysis used an unweighted average methodology to evaluate site volume and outcomes. In this methodology, the unweighted results reflect the average of individual hospital mortality rates without accounting for procedural volumes. This can yield variable results, especially when analyzing small sample sizes. In contrast, The use of weighted averages reflect the actual mortality rates seen in the patients treated across all centers. Additional data regarding these methodologies are included in the first slide. The slide at the bottom of the page 1 highlights the flaw using unweighted averages versus the conventional weighted averages. When considering this, the actual mortality rate seen in patients treated at low volume centers is 3%, not 4.4%, which is comparable to the higher volume centers. And looking at page 2, top of the chart, using the conventional average weighted methodology, this illustrates statistically significant reductions of mortality over time. The mortality difference between the high volume and low volume centers also converges in the most recent years. You can see this in 2017 that there is no difference in outcomes. So as you consider the questions posed to the panel, please consider the methodology used in these analyses regarding volume and outcome. We believe the use of conventional weighted averages provides a more representative and accurate depiction and assessment. Thus, I believe that achieving quality outcomes must be balanced with appropriate patient access. Other speakers today have underscored the importance of patient access already. So in the interest of time, I'm going to move through the next few slides. Thus, in conclusion, we believe that CMS policymaking should maintain quality while protecting patient access to TAVR therapy. Medtronic does not believe there is sufficient evidence to modify the current operator and facility outcomes and requirements to the TAVR NCD at this time. Thank you for the opportunity to present.
Thank you very much. Next up is Megan Coyle-Wright, Dr. Megan Coyle-Wright, who's the Associate Director, Structural Heart Disease Program, Heart and Vascular Center at Dartmouth-Hitchcock.
Thank you for the opportunity to address these important questions about how we provide care for our patients with aortic stenosis. So today I'm representing myself as a cardiologist, my patients. My institution provided support for me to come down Dartmouth-Hitchcock Medical Center, the most rural academic medical center in the country. And I'd like to speak from my experience, as many of us have, the experience of sitting in clinic with patients who have very different goals and preferences than I do, and listening to them. My disclosures are that I speak on shared decision-making to clinicians, hospital centers, industry, now government, and I learn and listen about shared decision-making from my patients. We're here today to ask, what is the evidence? We love looking at the evidence as cardiologists. We pore over it. We start with our clinical research, and thanks to many of the leaders in the audience, we have a lot of evidence about the safety and effectiveness of this therapy. That goes to our guidelines, which we've seen, expert consensus documents, and then leads us here to figure out how we're going to create policy to ensure adequate outcomes for our patients. But we're just starting to focus on the fact that maybe at the very top of this curve, are we asking the right questions? What's most important to patients? And we heard today, you all picked 4 variables. Those aren't necessarily on my list. So we need to think about what matters to patients. Does the small difference in mortality, in-hospital mortality between the varying centers, is that what's most important? We've answered Medicare's questions from the original NCD. How does the real-world population differ from those in the clinical trials? Very similar patients with improving outcomes as the technology evolves and as we share best practices with each other. I think that's the beauty of this therapy. We've been great about sharing what works and what doesn't, and that's helped improve outcomes for patients. Now, I know the men and women of the panel and Medicare are committed to serving Medicare beneficiaries. That's what you're in the job for, but I think it's actually the mission statement of the Office of Minority Health within Medicare that says it best for what we should focus on, and that is to ensure that the voices and needs of the populations we represent are present as we develop, implement, and evaluate policies and procedures. That the voices and needs are present. And I would argue we haven't asked those questions yet. So we have a lot of different outcomes that we've decided as scientists and physicians are important, But now we can move to processes where we make sure that we listen to the patient voice. And when I say to a patient, when I sit down in clinic, they don't ask me how many I've done or what our outcomes are. They ask me to take care of them there in the community. It's a different experience, but it's mine to speak of. And specifically, I don't want to exchange best patients. I want to exchange best practices. And I'll just share a story with you, not the patient's real name, but a real story. Mrs. Richardson, who had a valve problem, and she needed to have a transcatheter valve placed, but it was in a different valve position. And at our community hospital, we weren't offering this yet within the research trials. So I spent hours preparing the PowerPoint, getting the slides and the films down to Boston, conference calling with my partners, and she called me a week after the appointment was made and said, "I will not travel. I won't go there unless you go with me." And I don't say this to boast. I say it that it matters to patients to get care in their community. She died 6 months later of heart failure. And I think about many patients like that who've refused to travel and how important it is. And it's specifically important to vulnerable populations. We've heard about a couple of them. Number one, women benefit more from TAVR than SAVR and yet get it less. We've learned from our national research endeavor called WIN-HER, where we're looking at how do we get women involved in cardiovascular trials? They tell us, listen, I'm a caregiver, grandchildren, my husband. I can't travel. I have all these other responsibilities that are just as important and, in fact, for some women, more important than the differences in mortality. It's our job to give them the information so that they can tell us what is best for them. And we have that information. Similarly, for African American patients, there's no doubt that that category of patient refusal has a lot to do with having racial concordance and congruence with their providers and making sure that we're communicating in ways that match with their experience. And finally, patients with low resources in rural areas. There is a lot of data already out there that shows that it's difficult for them to access care. Not for us, for me to drive down, not for me, but for understanding that the values and preferences are different for our patients. We've got data out of North Carolina showing that rural populations aren't accessing AVR, and we've got the heat maps to show the very low penetrance of TAVR, that we're not treating the patients that need it. A study from Dartmouth a long time ago asked patients, let's just say the mortality risk increased from 3% to 6%. It doubled. Would you go to a different center? 45% said, no, I still want to stay here. You could argue maybe they don't understand the numbers, but let's trust our patients. There are other things that are important to them besides that chance of a different mortality.
Please wrap up.
We just concluded another study recently, and patients told us if we're going to consider new therapies, we need to discuss it with a trusted physician. So those conversations are needed and best held in a shared decision-making process where we present the data to patients. We're the experts in that, and they're the experts in their values and preferences. And then together, a true shared decision can be made, and I think that's how we'll improve our outcomes together. Thank you.
Thank you very much, Dr. Coyle-Wright. We now have a period for open public comments. There was a sign-up sheet for non-scheduled speakers out front. We have approximately 7 of them, and I'd like to ask them to come to the microphone. You each have 1 minute. I'd like you to start with your name, your affiliation, and your disclosures, after which time I will start the clock on you in case you have, 2 or 3 minutes of disclosures. And I apologize, I'm doing my best reading. Michael Deeb from the University of Michigan.
Good morning. My name is Michael Deeb, and I represent the University of Michigan. U of M would like to acknowledge that the disparity of access to care is real and exists in isolated geographical areas such as Wyoming and in low-income socioeconomic underserved areas such as rural Alabama and Georgia, not in large urban areas, and certainly not in Southern California, as we heard earlier, where the ratio of patients' lives to TAVR sites is among the best in the country. The majority of low-volume sites is not in the underserved areas, but in the overserved areas of high access and significant competition. U of M would also like to bring to the attention of the MEDCAC panel another major reason for patients being underserved, and that is financial. If you look at the 2 DRGs for reimbursement for TAVR in the underserved areas, it is on average $35,000. If you look at the manufacturer charge to the institution for the TAVR, it is between $30,000 and $35,000 per case. This leaves the institutions approximately $5,000 per case to cover all the remaining costs of the entire procedure.
Your time is
including
up.
Facility and resources. Thank you.
Thank you. Next up is David Cox, and can I ask also Robert Subedu to come up after Mr. Cox?
On behalf of over 3,000 U.S. interventionalists who are SCI
Please your
members.
name, affiliation, and disclosures, and then, thank you.
David Cox, SCI, no disclosures.
Thank you.
On behalf of over 3,000 U.S. interventionalists who are SCI members, thank you for allowing me as president of SCI to share our views. Quality of programs doing TAVR remains the most important goal, and we believe that all programs, but especially low-volume programs, are charged with the need to know their data and to do internal reviews to improve it, and failing that, to turn to external reviews to help improve poor performance. All that's pointed out in our paper and presentation, and that outcome data should be transparent to patients. Secondly, we cannot overemphasize the importance of the heart care team. Our presentations and paper emphasize that we now have to focus on imagers who help us with echo and CT, as well as 24/7 pacemaker backup. If you can't do that at your hospital, you shouldn't do TAVR. Finally, we believe SCI should be involved in a massive educational effort to educate both patients and primary care practitioners about aortic stenosis in the hope to improve access and improve mortality. Thank you for your time and
Thank you very much. Robert Subedu. I'm sorry if I'm mangling. Okay. Tom Nguyen.
My name is Tom Nguyen. I'm a cardiothoracic surgeon in Houston, Texas. As part of my disclosures, I'm a consultant for Edwards Life Sciences, Abbott, and LivaNova. We've seen the transition in treating TAVR patients from high-risk patients to intermediate-risk patients and most likely low-risk patients. One can argue that it's safe to do TAVR in these lower-risk patients and lower volume centers because, well, they're lower risk. But I want to build an argument against this, or for the contrary. As Dr. Joe Bavaria previously presented, there is some data to suggest low-volume programs performing TAVRs on lower-risk patients are having or might have worse outcomes. I would like to argue that these low-risk patients, there's an increased need to have perfect outcomes in these patients. Outcomes for low-risk patients need to be perfect, and this is why it's imperative to have qualified surgeons and cardiologists involved and available and maintain strict criteria for TAVR programs. If we do a TAVR on 85-year-old prior CABs, end-stage renal disease, COPD, if a complication occurs, most surgeons will be less likely to intervene. But if we do a TAVR on a 6-year-old bicuspid, otherwise healthy, and complications occur, we will intervene, and our surgical procedures can be life-saving. These patients will be more and more of our patients as we see a trend towards lower-risk patients.
Your time is up. Thank you very much. Dr. Nguyen, after this, could you see Ms. Ellis, please? Also, thanks. Richard Wright.
Good morning, Richard Wright, Providence St. John's Health Center, Santa Monica, California. I have no conflicts. I paid my own way. I also am the cardiology advisor to the RUC, and I co-chair the Medicare Contractor Advisory Committee for California. Several points. Number one, I don't even know why there's an NCD for TAVR. Having been involved in LCD development for a long time, NCDs are supposed to be for coverage. Everybody agrees here it's a terrific procedure. I would suggest that CMS consider retiring the NCD. I just don't see why it has to exist. Number two, as Dr. Goldberg said, the 80% of the hospitals that don't do TAVR were not represented on the ACC expert consensus document. I don't understand why that's the case. Number three, why the focus on PCI? We did 400 Watchmans at our facility. They don't count. We live in a place where we have less than 2% smokers. Our STEMI volume is down 70%, and somehow we get penalized for being conservative for doing PCIs. We don't do elective PCIs very much at all. I don't think that should prohibit us from doing TAVR. Thank you.
Thank you. I'm sure we'll all have RUC questions for you later. Ron Waxman. Sorry for your...
It's fine. I'm Ron Waxman. I'm the Associate Director, Division of Cardiology at the MedStar Washington Hospital Center. My disclosure is that we received grants from both companies, Edwards and Medtronic. I have 4 points, very short. First of all, in 2019, going to have a moving target of TAVR. The TAVR of 10 years ago, 7 years ago, 5 years ago, and nowadays are going to be different. We're going to see less and less surgery because by that time, probably going to have also low risk approved. In our own experience with our low-risk TAVR, which we presented at the CRT meeting, 125 patients, 10 centers, low volume did as good as the high volume center. Thirdly, I don't understand why we need 2 signatures of surgeon. If we have one surgeon that does it and does the procedure, isn't that enough? And the last point is the TVT registry. It is taxing. Our institution pays about $500,000 a year to get this information. While this information is important, I think we should be revisited. What should we ask? How should we get the best information? And who should sponsor that? Institutions cannot carry that for a long period of time, especially when they come to 400, 500 cases a year. Thank you very much.
Thank you very much. Next up is Matt Austin.
Good morning. My name is Matt Austin. I'm a faculty member at the Armstrong Institute for Patient Safety and Quality at Johns Hopkins Medicine, and I have no disclosures. I'm actually here today speaking on behalf of the Leapfrog Group, a nonprofit based out of Washington, D.C., that represents large purchasers of healthcare that buy healthcare benefits on behalf of their employees. Decades of research have demonstrated a very strong link between hospital volume and better outcomes for patients for many high-risk surgeries. These better outcomes include reduced mortality rates, reduced complication rates, shorter lengths of stay, and lower costs. And while we recognize that we need to ensure, while we recognize the tension with ensuring access for patients to TAVR, we firmly believe that the establishment and use of a minimum volume standard is important to patients. Thank you.
Thank you very much. Next up is Susan Peshin. I'm sorry if I've mispronounced your name.
Actually, you did great. I'm Sue Peshin, and I serve as president and CEO of the Alliance for Aging Research, a nonprofit in Washington, D.C., and we have received funding from Edwards Life Sciences. I wanted to first mention, there's been a lot of mention of older adults and the impact on older adults of heart valve disease in general and aortic stenosis in particular. And I just wanted to emphasize to all of you that the importance of independence to older adults and maintaining their independence shouldn't be undervalued in this context of setting some guidelines for the NCD. 12 million Americans, according to Pew, 65 years of age and older, live alone, and 7 out of 10 of those are women. So the issue of independence is as practical for a lot of these folks as it is psychosocial in nature. So that should be taken into consideration as you look at these issues. We would like to see more transparency with the TVT registry data. We want to see some of these measures on Hospital Compare and not just within the associations. These measures deserve, to be accessible to the public.
You're out of
and there
time.
has to be a better way to access this data. Did you say my time?
You're out of time.
Oh,
Yes.
okay. Thank you so much.
Thank you very much. One more time, Robert Chubedu.
Yes, good morning. Real quick, just thank the panel and the audience and colleagues for their presentation. I am Robert Chubedu, Chairman of Cardiology at Cleveland Clinic, Florida, also Section Head of Structural Heart Disease at this institution. Formerly trained at Mass General in Structural Heart Disease in 2008, and I've been able to witness this wonderful technology and take care of many, many patients. As a single operator, we've done over 300 TAVRs and have proctored many in the community. We have a real challenge today with the existing guidelines. We are a transplant center. We take care of the sickest of patients. We are a quaternary care center. And on a day-to-day basis, we see no less than 2 to 3 TAVR consults. I have to struggle across hundreds of miles of my month-to-month taking patients to other sites because we can't do TAVR at our facility. And part of it is because of the PCI volume requirement. We, as a quaternary care center, we don't take care of the day-to-day PCIs that we see all the time in local community hospitals. So we endorse and strongly support the updated revision of the society, lowering the PCI volume as a metric of quality for TAVR. And would like to just kind of voice that and encourage that. So I congratulate the committee for taking time to revisit and looking at these volume and metrics. I think just to finalize
Please wrap up.
Yeah, just one question that I think we have missed all along is we've emphasized the differences between one volume and low volumes and the potential impact on 1 or 2% differences in mortality, but we have lost sight of potentially the mortality among many other patients that have waited 3 to 4 weeks to get an appointment, that are living, 600 miles away from centers without TAVR access. Thank you.
Thank you. Dr. Cabedo, just disclosures, please.
Yeah, I have no disclosures.
Great. Thank you very much. We're going to thank you, everyone, for your attention and for the speakers. We are going to break for lunch. We remain ahead of schedule. Thank you for that. We will reconvene at 12:40. In here, most important, the speakers from this morning will be part of a conversation. Please, speakers from this morning, if you'd like to participate, we hope you will. Please be back here on time at 12:40. Thank you. Oh, I'm sorry. I'm sorry, the speakers have reserved seats here in the front row. I don't know if there are names or... No. Okay. All right, thank you. Enjoy your lunch.